sharing your Saturday morning and early afternoon with us. My name's Joy Baird. I'm the support group leader in Sacramento, and Jessica Milanis is my co-host today. She does the San Francisco support group. And we know we have many of you from Northern California, but many of you from other parts of the country, and we're really happy to have you with us today. This is the first time we've done this in Northern California. And so we are so grateful for our speakers today. We have 3 neurologists from Stanford University, one from Stanford, one from UCSF in San Francisco, and one from UC Davis. And I'll have Jessica introduce the first speaker, but we have Corey Fabstein, our 4th hour. She's going to be talking about stress management. So Jessica will have you introduce Dr. Mupidi for our 1st hour, and then we'll have a panel discussion at about 1 o'clock or 11 o'clock with Dr. Mupidi, Dr. Mark Taralange, and Dr. David Richmond. Those will be the first 2 hours. We'll have a short break, a clinical research and trials update from Dr. Richmond, and then another break, and then our stress management. So Jessica, go ahead.
Hi everyone, thanks for joining us today. So our first speaker is Dr. Mupidi. He is of Stanford. He's a clinical associate professor, and he's been doing a lot of really awesome work with the International MG and COVID-19 Working Group. He's going to have a lot of great updates to share with us. So I'll let him introduce himself a little bit more and go ahead and start his presentation.
Well, good morning. Thank you for joining on a Saturday morning. Thank you, Jessica, for inviting me. I'm going to share my screen. And the way I was going to plan to do this, so give me 1 second. Let me make sure I get this right. Share screen. And let's see. Can you confirm that you can see this PowerPoint, Jessica? Is this okay? Yeah. I'm going to keep it in this format. If I change it to presentation format, I can't see the video. I hope you can. I didn't quite hear that, but either Jessica or Joy, if you can see my screen, I'll get started.
Yes, we can.
Good. Okay, good. So I was going to briefly talk about some of the myasthenia work, along with myasthenia and its relationship with COVID, some of the work we have done. Maybe I'll talk about it for 20 minutes or so, and then we'll go through some of the Q&As. So I want to make sure that we are all on the same page with some of the data that we have currently and some of the views about COVID and the relationship with myasthenia. So one of the things a group of us, myself, a few more folks like Jeff Guptill, Richard Novak from Yale, Jeff Guptill from Duke, and quite a few of the international colleagues were concerned about COVID and the effects of COVID on myasthenia. And so we set up this organization called CARE-MG, COVID-associated risks and effects in myasthenia gravis. And it's truly an international physician-reported registry. And thanks to MGFA, if you go to MGFA website, we actually update every couple of weeks some of the data that has come out from this. At least the sort of the bird's eye view of the data, not necessarily every minute piece as we try to analyze, we will update. And that particular web page on the MGFA website also has links to publications and other things that have come out of the study. And so I know everybody knows about this, but it's always good to just go through some of the basics. You know, COVID-19, it's caused by a SARS-CoV-2 virus. It's SARS-CoV-2 because there has already been a while ago, but it was much more contained, not like the current pandemic. There are certain population patients which we know are at higher risk. Patients who have other comorbid conditions such as diabetes, hypertension, And then I highlighted old age because that is probably one of the biggest sort of comorbid conditions, which puts you at a really high risk. And so it's critical if you have any of these, but certainly if you're older, that you do absolutely everything you can. We like to think that anytime there is a viral infection, immunosuppressive agents certainly would increase the risk of acquiring the virus infection. We worry that if you're immunosuppressed, the viral infection might be much more severe. And why myasthenia? In myasthenia, we use immunosuppressive medications to manage disease, steroids and other oral immunosuppressive agents. But additionally, patients might have difficulty with breathing, patients might have difficulty with the swallowing muscles. They might have other conditions like diabetes. Sometimes that can happen because patients are treated with steroids, for example. And so you could see how the myasthenic patient population might be at a slightly higher risk of not great outcomes if they were to get COVID. There are some specific populations that we always worry about whenever there is a pandemic or an infection. We always worry about patients who are immunocompromised or immunosuppressed because they might not be able to fight against the infections. So it's just not the folks in the myasthenia field. Lots of other international support groups and patient registries were worried about how their patients might do when the pandemic started. So there are some registries, a lot of them have their data, at least sort of bird's eye view data online. So if you ever want to sort of go in to look into them, there is a rheumatology, rheumatoid arthritis data set. There is one on multiple sclerosis. There is one on inflammatory bowel diseases. And there might be lessons that we can learn from these databases as it relates to risk with immunosuppressive agents. But I still believe that the myasthenic patient who has myasthenia might be at a slightly different risk stratification, just because somebody who has rheumatoid arthritis has different degrees of disabilities compared to somebody who has myasthenia. And so it might or might not always translate across, We were also concerned about the overall myasthenia care. Now, this was a year ago, so almost a year ago. But some of you might remember that there was lots of publications and sort of media news about a medication called hydroxychloroquine, and also another antibiotic called azithromycin. These were sort of being publicized as potentially medications to prevent COVID, medications to treat COVID if you were to get it. There was really not a lot of data right at the beginning. In fact, over a period of next few months after like spring of last year, there were studies which said that these particular drugs were not really useful. They don't actually help with COVID. The problem from a myasthenia point of view is that these two medications, hydroxychloroquine and azithromycin, actually can make myasthenia worse. Like a lot of medicines which can make myasthenia worse, these two medications can make myasthenia worse. And that was a sort of a huge concern personally for me and a lot of us who take care of patients with myasthenia. I recall sending multiple messages to different patients, either asking for my take as to whether they should take it. And I'm so glad that they asked me because I could tell them, please don't. And so that was the number one concern we had. Although I'm really happy to hear that that was sort of short-lived, even though it was scary, short-lived few months. There was also some concern about should patients are requested, or should I be stopping my immunosuppressive agents? Because maybe, if I stop my immunosuppressive agents, maybe I won't get COVID because I'm not immunosuppressed. The reality of it is that that's just a sort of a tricky way of solving the problem, because if you stop your immunosuppressive agents and you get weak and you get hospitalized, you might actually be increasing your risk of getting COVID. So none of us recommend that, and so that was one problem. And some of these concerns were sort of floating around. We're all hearing it from patients and support groups. So the group that works with CARE MG project actually had a little guidance statement just from our experience of dealing with other infections on how best to manage myasthenia. And there's another syndrome called Lambert-Eaton myasthenic syndrome during the pandemic. And then we were also sort of looking at data as to, how bad is it to have immunosuppressive therapies on board. There are some publications which said that if you have an immunosuppressive therapy on board, after you get the COVID, maybe the fact that you're immunosuppressed might make a difference, because you might recall, for example, currently, when patients are hospitalized with COVID, one of the treatments that they get is dexamethasone, which is a type of steroid, because COVID sort of revs up your immune system so much, so that dexamethasone actually helps with that. So you can imagine being in, sort of, most of you were there anyways, in spring, summer of last year, how every couple of days there would be a new piece of data. Very little of it was evidence-based, and so we were all worried about how this might pan out. That was the impetus behind sort of creating this registry. And again, as I said, the data, a lot of the data is already available on the MGFA website if you want to keep an eye on how things pan out. We launched it in spring of last year with a goal of sort of identifying patients who have myasthenia and then who get COVID, and sort of briefly learning about them as to what happens to them. How often do they get worse? And what kind of treatments are they getting? And how do they do? And I will still say that even though we have grown this, and I think as of last week, I don't have the full data set yet. I think we've crossed like 200 or 220. But we still, a lot of these cases that we have are from large university centers. And so we might be slightly biased towards patients who've had bad outcomes. Those patients who had COVID and didn't have to go to the hospital are likely not yet reported, but we're trying to capture those events as well. And so this is just one sort of snapshot of what's currently available as of like 2 weeks ago. And as I said, the number has crossed over 200. And so you can see that we are sort of an international group represented by sort of multiple countries, and we're trying to sort of grow into other African countries and South American countries and so on and so forth, and trying to reach out to physicians to get a improved representation. Most of the patients had sort of COVID positive diagnosis testing, but we also included some who were not tested. Again, if you think back as to how things were about a year ago, it wasn't so straightforward that if you think you had COVID, you couldn't just walk up and get a COVID test. There was sort of a lot of delay in getting COVID testing, a lot of delay in diagnosis. And so sometimes people were just presumed to have COVID. I don't want to scare you. And this is where I was trying to say that this data is probably biased towards bad outcomes, but patients seem to have some bad outcomes when they have myasthenia and COVID. We hope to get to 200 and 300 at higher numbers, and hope to get to some of the milder cases that have definitely happened. And so hopefully that will give us a true sort of incidence of, how bad is it to have COVID and myasthenia, and are patients with myasthenia truly different from other immunosuppressive diseases? What does happen is that this is a table from sort of a smaller data set, but you can see that the blue, so most of you might know, but there is something called MGFS status, so Myasthenia Gravis Foundation of America status, which is sort of a classification of how bad somebody's myasthenia is. So for example, 5 means that they're intubated in the hospital. Asymptomatic is they don't have any symptoms. 1 means that they just have symptoms in their eyes. 2, 3, and 4 represents mild, moderate, and severe in that sort of ascending pattern. And the key take-home message is that before COVID is where they are blue, and then after COVID, where they're orange. This is the same number of patients. So you can see the rightward shift in the number of patients suggests that these patients did get worse. So not every one of them, but overall, after having COVID, for a few weeks, patients did get a little bit worse and required additional therapy. So that was sort of panned out as we worried about that this might happen. Patients do get worse after COVID, one of the reasons why we care so much about it. And so briefly, this particular registry is still active, and we're still collecting data. And if you are seeing any of the neurologists, other physicians here in the Bay Area or California, anywhere in US, for example, and you've had COVID, and you can always ask your physician to report it. It'll take about 5 minutes of their time. It's only like 10, 15 questions, quick buttons that they need to press. And they don't even have to do anything special. They just go to the website, the MGFA website, and report the data. And we want to thank MGFA again for sort of hosting the website and letting us put the data out. We do hope to keep the data as publicly accessible as possible. I'm hopeful that by spring of this year, by summer of this year, we'll have a lot more cases, so we'll truly understand which patients got worse and what are the factors that made them worse. Is it just the age that made them worse? Did they take certain drugs that made it worse? So on and so forth. There is some data that from other data sets, like for example, from MS, where they've had many thousand patients who've had COVID. MS is much more frequent than myasthenia in population. I think the biggest factor that led to bad outcomes in patients with MS after having COVID was age. There is some data that being on certain medications like Rituximab might also cause bad outcome. But again, I think a lot of this has to be looked at the fact that patients, or is it an older patient or a younger patient? Because I think age still is probably the most critical factor in terms of what happens. Now, the good news is that we have vaccines. I wouldn't go out and quite say that we are done with the pandemic. I'll share this story that I remember at spring of last year when this happened and lots of the shutdown happened in the Bay Area and we started seeing patients online. I remember telling a patient of mine that, we'll meet online, but don't worry, by summer, we'll be done. I must have meant summer of 2021 because I had no idea that summer of 2020 would be the way it was. I don't even know if summer of 2021 would be dramatically better. I truly hope it would be. But the good news is that there are these 2 vaccines that have been approved under sort of FDA emergency use authorization. Most of you, these are sort of scientific names, but we all know them as Pfizer vaccine, Mrna Vaccine. Both of them have 2 doses. They're given either 3 weeks apart or 4 weeks apart. There are other vaccines that are in the pipeline, but I'm not aware of anything else, at least that's approved in the US. Some of the other vaccines that are in the pipeline are single-dose vaccines. And these 2 vaccines are what we call mRNA vaccines. The other vaccines have a slightly different sort of older technology in terms of making the vaccine. And most of you probably know what this means, but it's essentially mRNA vaccine is that you get a small particle of the vaccine, of the virus as a vaccine, and your body produces this spike protein from the mRNA, and then your body reacts to that protein, develops antibodies, so that if you were exposed to the virus, then you won't get COVID, or you won't get as bad of a COVID as you might otherwise without the vaccine. The remarkable thing is that both the vaccines are really, really effective. They've been tested in obviously thousands of patients. For example, this is the Pfizer vaccine. It was tested in almost 43.5 thousand patients, for example. Half got the drug, half got the placebo. And you might have seen these either online or read about them in publications. Basically, this is looking at the y-axis here, looks at the incidence of developing COVID. The x-axis is looking at the number of days after you got the vaccine, the first dose of the vaccine. The remarkable thing, obviously, once you get the first dose of vaccine, you can see that your incidence rate really is not that much high. It doesn't go up at all. Whereas if you got the placebo, it keeps going up over a period of time. The remarkable thing is this part, actually, which is like a sort of a zoomed in version of this area. And you can see even after, so the red line is, again, those who got the vaccine. Blue line is those who got the placebo. You can see about maybe 12 to 14 days after the first dose of vaccine, the two lines separate out. So the protective benefit of the vaccine kind of shows up within 2 weeks after the first dose, not even the second dose. And so that's quite remarkable that we are able to experience this benefit in real life. The same thing happened with the Mrna vaccine too. Again, it's given every 2 doses, every sort of 4 weeks apart. And then you will see that pretty much soon after sort of 1 dose of the vaccine, the lines start to separate out, and the risk of getting COVID is lower, and then the more important thing is risk of getting severe COVID is also lower. And so I think from the data that we have, these 2 vaccines are clearly effective in population. And I know there have been some concerns about adverse events. A lot of these adverse events are sort of the local reactions at the injection site. I personally have not had a patient who had a sort of a severe outcome, but I know there are occasional reports of Bell's palsy, which is a type of weakness of the facial muscle. But if you look at CDC, which monitors all of these reports, the feeling was that the incidence of these things is not really higher than what usually happens in the community over a period of time. So it's quite unclear if any of these additional symptoms are truly related to the vaccine, or the vaccine is definitely making it worse. There were some questions. I think this is my sort of the last slide, and then we'll go through some of the questions. But some of you sort of put in some questions, and I wanted to sort of address them in this format because others might be wondering about it. The first one, and this I can't overemphasize, but I also don't want to dissuade anybody from getting the vaccine, is that when we test any drug, for example, there is a population of people that they select. And these population people represent sort of all cohorts of life, older, younger, patients who have diabetes, patients who have hypertension, so on and so forth. One thing they did not do in the 2 vaccine studies that I talked about, the Pfizer and the Moderna vaccine, is that patients who are immunocompromised or patients who are immunosuppressed for any other reason were not included in the 2 trials. And that's critical for us, at least in myasthenia, is because if you are on prednisone or other immunosuppressive agents, and you had said, oh, I want to be in this clinical trial for the vaccine, you couldn't be, because those patients were specifically excluded from the trial. Probably for many reasons, because it was a sort of a novel vaccine and we didn't know how well it would work. And so I understand why. The problem, of course, is that when a patient who is immunosuppressed wants to know how effective the vaccine is for him or her, it's difficult to know, because the reality of it is that a person who represents an immunosuppressive cohort of patients was not included in the clinical trial. So that's one problem. There is no way to get around it. They did include patients who have HIV in the trials, but it was only well-controlled HIV, not poorly controlled HIV or HIV with severe immunosuppression. So again, there's no way to extrapolate that data. And so if somebody looks at those 2 papers that I said, and then comes up to me and says, well, Dr. Muppidi, this is all great, but somebody who represents me in this population is not in the study. And that's a true point. That's a true point. But having said that, in my personal experience, and I've had few patients of mine who've already had vaccines, nothing bad has happened to any one of them. And if you look at the CDC guidelines, nothing bad has happened to anybody that is immunosuppressed for, because of other reasons, because of their disease or because of their medications. And so I still think that all patients should get the vaccine, unless there's a specific reason why they can't get the vaccine. Like they've had history of allergies to some component of the vaccine would be one, for example. But if a patient asks me, can you provide me the efficacy data that represents me? Unfortunately, I can't. There was one really fascinating question about plasma exchange and vaccine efficacy. I don't know who asked that question, but I want to make sure that I explain this before I sort of go into the answer. So plasma exchange is a form of therapy that sometimes we offer patients with myasthenia, which is where, we take your blood, filter out the antibodies and give it back to you. A lot of the times we do this acutely when somebody's not doing well and they're hospitalized. Sometimes we do this when we tried other drugs and patients are not doing well on other drugs. So one of the concerns is that when you have a plasma exchange treatment given, your antibodies get filtered out, which is what it does. Your acetylcholine antibody, the antibody that causes myasthenia, does get filtered out. And so there is this theoretical concern, I'm assuming for the person who asked this question, is that if I get the vaccine and then if I'm on plasma exchange therapy, the antibodies that I produce from the vaccine to fight against COVID, if I were to contact it, would they be filtered out? And that's a great question. The reality of it is we don't know. What we do know is that in the past, when they did plasma exchange studies in patients who've had routine vaccinations for tetanus and all kinds of things that we all get routine vaccinations for, they looked at the antibody titers for those vaccines before the plasma exchange and after the plasma exchange. And the titers in your body after the plasma exchange were still sufficient to prevent an infection. And so while it's true that plasma exchange does filter out the antibodies, it is not changing the efficacy of vaccinations when it comes to other diseases, but we don't know about COVID. Okay. I will just share an anecdote. This is anecdote. Don't take it as sort of final worded anything. We have had one patient who had COVID, and the patient was on regular outpatient plasma exchange. And the good news is that after COVID, the COVID antibodies that she developed have persisted for many, many months, even though patient was on regular plasma exchange. And the extrapolation there is that the vaccination is supposed to produce even higher levels and more robust antibody response than actually having COVID. And so I'm hopeful it won't make a difference, and that if you have plasma exchange, if you get plasma exchange. But that's a great question, because we don't quite know the answer, and certainly something to talk to your doctor about. Is there a way to monitor it, and so on and so forth. There were also a couple of questions about what if you're on IVIG, what if you're on other antibody therapies for your myasthenia. Currently, CDC basically says that there is no sort of interaction that we know about. You should stick to your regular regimen, and you should get your COVID vaccine when it's offered to you, unless there is a contraindication for not getting it. And I think that's a reasonable assumption. I don't think that there is any sort of significant data out there to help us sort of time it any better. Anecdotally, again, we think that certain therapies does reduce the risk of vaccine efficacy. So one therapy is called Rituximab, which is a monoclonal antibody, and it works against B cells. B cells are critical for antibody production. And so if you are on Rituximab, you just had Rituximab, and then you had the vaccination, would that reduce your ability to develop adequate antibodies? On paper, I think so. In practice, we don't know. We don't know the answer to that in practice. So that's something to certainly talk to your doctor about. But you know, it's also the reality of it is that if you were on Rituximab, you already had it, and then you get an offer to get the vaccination, I would say just go ahead and get it, because can you wait it out and then try to get it at a later point? And I don't know any more than most of you regarding sort of vaccine availability and distribution from sort of a county level and state level, because those are the sort of the teams that are distributing it. And so I had recommended to all my patients at the moment they can get the vaccine, unless they have a side effect, they should get it. While we do all of that, I think all the other things that we do in terms of protecting ourselves and protecting our colleagues, protecting our family, about contacts and isolation and avoiding things that increase the risk of spread of COVID are critical. I think some of the models that have sort of looked at how COVID spreads and how many patients might be at risk, and suggested that some of these measures are probably just as effective, if not more effective, than sort of full vaccination of the society. And so even if you get fortunate enough to have had the vaccine, if you look at the two tables that I had shown you, it's not that the post vaccination patients did not get COVID at all. There is still a small risk that you can still get COVID. It is small, much smaller than not having the vaccine, but it is there. So as I was telling my 10-year-old, it's not a license to do anything and everything that we want to do in our lives. We still have to sort of follow some of these recommendations regarding how to avoid spreading the vaccine, spreading the COVID. So I'll stop there, and then I'll take some questions.
Yeah, so we had quite a few questions that were submitted during this time. Some of them you've already addressed, but I just wanted to
Sure.
reiterate them just to make sure that we're getting everyone's questions addressed. So the first question was, how do I participate in the CARE MG study? And so I think you mentioned it was physician reported.
Yeah, so currently, yeah, thank you for that question. It is currently physician reported. There's nothing, we have nothing against patient reporting, but some of the questionnaires regarding sort of the MGFs status and things like that, although folks on this forum might be well versed with sort of those things, I don't know if everybody would be well versed with it. So it is physician reported. But I know physicians will tell you they have a lot of things to do, but this is a sort of a all physician effort. We all just basically donate our time trying to get this data together. And so I would just encourage your physician to report it. And if they give you a tough time, tell them Dr. Mupidi said that.
And
they can always call me and shout at me if they need to.
Perfect. And the link should be found at the MGFA website.
Yes. So the data is available if you go on your browser and then type in CARE-MG, it will actually take you to the website. It is on the website. You just have to go through sort of one of the drag down options. But if you you can just Google CARE-MG. It should take you to the website, which has all the information, sort of the bird's eye view information. We will try to update that every 2 to 4 weeks as you're getting more data. And we will also put up any links to sort of publications that come out of it, news bits that come out of it, because we want, one of the sort of the promises we made to ourselves as we are trying to create this is to make sure that the data is available and open as soon as it's available. Because we want the whole society to learn from this, you know, because the whole point of the exercise is to try to learn about COVID and myasthenia as quickly as we can and pass on whatever we learn as quickly as we can.
Great, thank you. So the next question is, do immunosuppressive drugs such as Celsat or Imuran affect the efficacy of the COVID vaccine?
Oh, great question. But easy for me to answer because we don't know. As I said in the beginning, in the two trials, both the Pfizer and the Mrna vaccines, in patients who were tested, patients who were studied in those trials were not on any immunosuppressive agents. And so we don't know how efficacious the vaccine is if somebody's on these drugs. I will just share my personal practice currently is that I'm asking my patients to go ahead and get the vaccine. Some of my patients are physicians, they themselves are physicians, and so they're fortunate enough to get the vaccine sort of earlier, maybe in December or January. And so we even wondered about checking the antibodies, because you can check the antibodies, just like if you had COVID, you can check the antibodies. You can check the antibodies after you had the vaccination. And would that be a way to sort of assessing that you developed the antibodies, you had some kind of immune response to the vaccine? Again, it's one of those things on paper, it sounds perfectly logical and scientific. The reality of it is that there is no data that let's say you develop the antibodies, that does it mean that you definitely had adequate response? We don't know. Let's say that there are no detectable antibodies. Does that mean that you had absolutely no benefit from the vaccine? We don't know. If you look at CDC says basically that at present, they don't recommend checking the antibodies after vaccination. Part of the reason is that it doesn't change anything that we can do. We don't have any data for getting booster doses. I don't foresee that happening anytime soon, for example. And so I think if you're fortunate enough to get a vaccine, and if there are no contraindications, I think you should go ahead and get it. But as I mentioned earlier, post-vaccination doesn't, unfortunately, yet give us the freedom to do a lot of things that we need to do to prevent COVID spread. Sorry, that's a long answer to a simple question, but.
No, that's okay. So kind of going with that question, somebody asked, does it matter if your IVIG and getting the vaccine are timed too closely?
Again, a great question. If you look at CDCs, it says it doesn't matter so much. Again, it's one of those theoretical concerns that when you have sort of high levels of IVIG in your body, will that bind to the antibodies that you develop from your COVID vaccination and somehow reduce the efficacy? In a scientific way, maybe there is some, I don't know. I've had a couple of instances where I tried to see if I can modulate the IVIG timing with the COVID vaccination. But the reality of it is that because there are two vaccination doses, either 3 or 4 weeks apart, it just becomes too difficult to even figure that out and then time them. And there is really no data. So I think if you're able to get the vaccine, I would say just go ahead and get the vaccine irrespective of your IVIG timing, because it would be too sort of difficult to get that timing right, even on paper, for example. And the reality is that if you're on IVIG for something like myasthenia, which means that you need it, and I would rather you not get weaker by delaying it or so on.
The next question is, are there any plans in the future to include immunosuppressed patients in the clinical trials of the vaccine?
Great question. I remember talking to some of the infectious disease colleagues of mine, trying to find out if that's in the cards. I don't know. What I think will happen is that there will be some population level studies after those who already got the vaccine, and we'll get some data regarding efficacy in those groups. So let's say there are 10,000 people who are immunosuppressed for some reason or the other. They've had the vaccine. How many of them end up getting COVID, for example? So there might be other ways we might get to that answer. I don't know if there are more trials being done just for immunosuppressive patients. I don't know the answer to it. But I guess the way I'm looking at it currently is that it is safe enough to definitely get it, even if you're immunosuppressed. Is it efficacious enough? We don't know, because they were not included in the original trial. Because it's safe enough, if you're able to get it, I think you should get it, unless there's a contraindication. And maybe we'll get the answer to the efficacy part in future. But since the community spread of COVID is still there, we all have to follow all the protocols anyway. So.
The next question is, do you have any idea of which vaccine type is better for MG patients? The new mRNA Pfizer Moderna versus adenovirus Johnson & Johnson or AstraZeneca?
Yeah, so I mean, I think the two vaccines, the Moderna and the Pfizer, seem to be safe. I've certainly not heard of any adverse outcomes in MG patients or immunosuppressed patients. I don't have access to I'm not aware of any large-scale trial for I know that the Oxford vaccine, there has been some data that's published, but at least not approved in US yet. So I don't have access to that data. The reality of it is that if you look at the efficacy rates of the vaccine in the community, not necessarily immunosuppressed patients, the other vaccines didn't quite hit the 90-some% efficacy. And so I don't think, at least in a large population, the other vaccines might be as efficacious. They still might be more than good in terms of preventing COVID. They certainly have the advantage of a single dose, so it could be given quickly and to large populations. It's one of those questions where if you're asking me, should I wait it out for the other one? I don't think we know enough to say that you should. From what we know about the two mRNA vaccines, that they seem to be safe. Yeah. There is, maybe if I can just answer one more question, Jessica. This is sort of some of the comments that one of the patients asked me in the past, is that how do we know, for example, this mRNA vaccine, because I'm immunosuppressed, doesn't cause COVID in me? I think, again, on paper, very nice, very logical sounding question. The reason we know that is because in the community, when patients got vaccine, it did two things. One, it reduces your risk of developing COVID, which is great because you developed antibodies. The second thing that it did, and this is probably the reason why there's no reason to worry about the vaccine causing the disease, is because the severity of the COVID also reduced. Because if the severity of the COVID, the fact that the severity of COVID also reduced means that it's not the virus replicating, it's your own immune system fighting against the virus. And so that's one of the reasons I really don't think that the vaccine causes the disease. There were some thoughts that because you're immunosuppressed, could that happen? I don't think so.
Thank you. The next question is, can you possibly get COVID antibodies from Ivig?
Great question. Yes, this is really amazing, this particular audience. Yeah. I think, let me put it this way. Most of you probably know Ivig is from sort of donated pool of blood or plasma from patients or from regular folks. And then they take out the protein, the immunoglobulin, and they sort of clean it up. And then this sort of pooled out of thousands of patients and to get one bag. So you would have to have COVID pretty rapidly throughout the country for the COVID antibody to get into your Ivig. As much as COVID has spread around the country, I don't think that has happened. It's not like millions and millions of people have already had it. It's also possible, I don't know the answer to this, is because those places where they collect the plasma are probably not including, for regular plasma inclusion, probably not including COVID patients. The reason I say that is because one of the treatments for COVID is actually something called convalescent plasma, which is if I get COVID and I developed antibodies, I can go, or I'll be asked if I'm interested to donate my plasma because I have the antibodies. And that plasma is actually given as a treatment for COVID patients. If you have bad COVID, you're in the hospital. So it's unlikely that out there somebody is donating plasma after having COVID that kind of gets into the IVIG. If they really want to donate, it probably will go to something called convalescent plasma, which is used as a treatment.
Okay, thank you.
That's a great question. Sorry, Jessica, I think you froze. I can't hear you, sorry.
Okay, okay, no. Oh.
Sorry, you froze
for
a second. Do you mind repeating it?
Yeah, sure. So would a third vaccine shot possibly be beneficial for patients who are immunosuppressed?
Yeah, amazing question. I don't know the answer to it. And that's one of the critical things about do patients who've had immunosuppressive therapy, should they get a third dose? I think in a few months we might know a little bit more about it because I suspect we will know sort of the efficacy of it in immunosuppressed patients specifically. At present, I know that's not practiced anywhere. Again, as I said, the patients who are immunosuppressed were not included in the trials, both for Pfizer and Moderna, but it doesn't mean that it doesn't work in that population. We just don't know it; they were not included, and so I don't foresee yet anybody being able to get a third dose. We just don't have any data for it. So.
The next question is for MG patients with mild symptoms, would it make sense to suspend immune suppressants prior to getting the vaccine?
I will just tell you my practice, and if this is sort of one of those data-free zones, so there could be variations in our thinking. The reality of it is that yes, you have mild symptoms, but you might have mild symptoms because you are on some kind of immunosuppressive therapy to keep it mild or keep it controlled, And so there's always a possibility that if you hold off your medications, you can actually get worse. It's very difficult to predict it. There is enough data that if you are on immunosuppressive medications and you're doing well, and if you want to come off them, we try to do that very slowly over a period of time. And so for all those reasons, I currently don't recommend holding off the medications for the vaccination.
Okay. So the next question is regarding wearing a mask. And so it's been recommended recently that people should wear 2 masks. This person is saying that they have a hard time breathing without a mask, and they're wondering what you recommend in regards to mask wearing.
Yeah, I saw some of the online news. I can't say that I know the underlying data behind the 2 masks, and the only time I don't wear a mask is when I'm in my office room, and so I share your concerns about wearing a mask. 2 masks, that seems very difficult personally for me, but I think it's the question of protection when you're out in the community among large groups of people, and the situation doesn't seem like anybody's following some of the current guidelines. It might be more beneficial to wear 2 masks, but I think a tight-fitting, well sort of closing mask certainly is better than nothing. And the reason for the 2 masks, I think some of it is because not all of us are sort of following some of the rules of mask wearing in terms of covering sort of both nose and mouth and how tightly fitting it should be and so on and so forth. That's I think that's a great question. And I realize it's not as simple as just wear a mask. For some of my myasthenic patients, that makes it very difficult to manage.
Yeah. The next question you kind of addressed before, but I'll go ahead and ask it again. So this person says that it's been 14 days since their second COVID dose, and they would like to know if they should request an antibody test to see how their body did with the dose.
So I had for everybody else, just to make sure we're on the same page, and this is a critical part of it, is that 7 days after the second dose is where we say that you have had adequate protection, because that's where the efficacy for the 2 trials were clearly assessed. And so because you would have had developed antibodies. If you look at the CDC recommendations, CDC says you really don't need to check the antibodies, because the thought is that irrespective of whatever comes up on the antibodies, it's not going to change anything, in a sense that you still have to do all the social distancing, masking, and everything else if you're outside to prevent COVID. There is still a chance that you can get COVID post-vaccination in the clinical trial. Patients had COVID in the clinical trial. So it doesn't mean that you can't have COVID. And so that doesn't rule it out. Would it make you feel better if you had tested the antibody and you have the antibody and you feel like something has actually sort of made a difference? I can see that point of view. I share that point of view, but it wouldn't change anything from what you need to do or what your physicians would ask you to do, whether they were able to detect the antibodies or not. Having said that, just so that I don't sound hypocritical, I have tested it in one patient of mine. But this particular person is a physician, and she was going to work to see patients. And since she was a physician, she was fortunate enough to get the vaccine slightly earlier. And so I was curious, she was curious. So we tested it, and she did have the antibodies. But again, the reality of it is that if she didn't have the antibodies, what would she do differently? Probably nothing. But yeah, that one instance I did test it.
So we have one more question, and just to let everyone know, Dr. Muppidi will be joining us in the next session. So if you do have any other questions that you think of, please submit them in the chat. And so our last question here is, if a person has iron anemia, should they get the COVID vaccine?
If they have iron deficiency anemia, should they get COVID vaccine?
Yeah.
I'm not aware of any sort of reason not to get that based on it, unless there is some literature out there that is sort of a specific question. But I'm not aware of any reason not to.
Great. Awesome. So I think that.
There were a couple of questions, yeah, Jessica, that I briefly saw. I will make sure to send. I think this thing is being recorded anyways, but a couple of folks asked if they can have the slides, so I'll send it to Jessica, and then if you want to distribute it to the group.
Great. Yeah. That'd be awesome. All right. Well, thank you so much. That was really informative. I think we all learned a lot, and we will have Dr. Muppidi joining us in the next panel. So if you guys would like to sit tight, we're going to start the next session in about 5 minutes. So if you want to take a break, now would be the time.
Hello, everyone. It's just about 11 o'clock. Yes, I'm actually not in California, so I'm looking at the time difference here. So, but we'd like to get started with the next session. And I'm having a little bit of difficulties here with my laptop and trying to access some information here. So if you'll bear with me another minute, we have both, all three, Dr. Mupidi, Dr. Taralange, and Dr. Richmond, that will be with us for this question and answer session. Many of you submitted questions prior to the conference, and we will go through those first. If you have questions that you want to submit, please do that in the chat format here. And if they are different from what, we'll try to get to all of those after we've taken the ones that were submitted prior to the conference. So send those in the chat, and if you'll wait just a minute here, I'm going to try to get the list of questions here. That's where I'm having difficulty.
In the meantime, can we have Dr. Tarlong and Dr. Richmond introduce themselves to the audience?
Yes, I think. Okay, is Dr. Richmond, are you a co-host? Have you been put as a co-host yet?
I see that I have share screen
Okay,
green, so I think that means it's okay.
okay.
Yes,
perfect.
he's okay. He's good.
Okay, great. Thanks for bearing with us here. All right, go ahead, Dr. Terrelange, and then Dr. Richmond, and then Dr. Mupidi. Some of you may have been joining us for the first time right now and missed the first hour. So we'll go ahead and have you each introduce yourself again, and then we'll start with the questions. Go ahead, Dr. Terrelange.
Hello, my name is Dr. Tara Long. I am an assistant professor of neuromuscular medicine and neurology at UCSF and split my time between there, the general hospital, and doing some outreach work in the Central Valley in Hawaii. I'm very happy to be here. I take care of a lot of patients with myasthenia, and I'm excited to share some thoughts with Dr. Mupidi and Dr. Richmond.
Great, thank you. We're so happy to have you join with us and appreciate your time. Dr. Richmond.
So I'm David Richmond. I'm a professor of neurology at UC Davis, and I supervise a large myasthenia gravis clinic. We have patients from all over, and I've been specializing in that for pretty much my whole career.
Great, thank you, Dr. Richmond. Dr. Mupidi.
I'm Sri Mupidi. I'm at Stanford. I specialize in neuromuscular, mostly myasthenia and some autonomic disorders. And I have to say, it's an honor to be in this panel with Dr. Richmond. I recall as a resident, a trainee, for those of you listening to him at a national sort of meeting many, many years ago. Even though we're in the Bay Area, I hardly get a chance to interact with the team at UC Davis as much. And I gave the first talk, so if you missed it, it was spectacular. I'm sorry.
It was very, very informative. Yeah.
It was great, thank you. Okay, I've got my list of questions here, and we submitted those to the doctors ahead of time, and what we're going to do is I have questions that we just kind of randomly submitted to the doctors, and we'll have them answer that. But certainly if there's something else that either of you three would like to share, even though the question wasn't directed to you, please feel free to chime in with your thoughts, okay? So the first one has to do with COVID, and again, these may have been asked in the first session with Dr. Mupidi, but I know some of you are just joining us on this hour. So first question to Dr. Richmond. Are there any studies being done regarding MG patients that have been diagnosed with COVID-19? And what are those studies trying to determine specifically?
So I'm not aware of any studies related to myasthenia in particular, but I have a few things to say about COVID and myasthenia. So we're talking about an autoimmune disease, which means also that your immune system is not functioning perfectly. And many patients with myasthenia are taking medications, which we'll, I guess, talk about in the next hour, that reduce the immune response as well. So myasthenia gravis patients are definitely high risk for getting COVID-19 and having the complications of COVID-19. So it's extremely important for every myasthenic patient, unless they have some particular other medical issues, it's very important for them to get vaccinated as soon as possible. Even patients taking high doses of immunosuppressing medications, it seems, get a pretty good response to the vaccine. So the other thing is, because of the high risk, if someone gets COVID, they should probably be treated with monoclonal antibody to prevent their having to be hospitalized or go into an ICU. The requirements for receiving monoclonal antibody treatment is that the disease has not yet gotten very severe. So it's only for patients who are not in the hospital yet. But because of the reasons I just mentioned, there's a lot of risk in patients who get the disease. And so they're the ones that this medication is perfect for, myasthenia gravis patients who develop the disease but are not yet sick enough to be hospitalized.
Okay. There was a little follow-up. Go ahead, Dr.
Can I add a
Martin.
couple of things?
Yeah,
I agree with everything Dr. Richmond said. And if you haven't heard the previous talk, there is this international survey-based project called CARE-MG, where we are trying to sort of, and the data is available on the MGFA website. We're trying to obtain data about outcomes for patients with myasthenia who've had COVID. It's not at a single patient's level. We don't collect any blood samples. We just collect their history and what happened to them. But I can't agree more about those BAM, which is one of the antibodies that is available if you have mild form of COVID and you don't require hospitalization. At least at Stanford, I know that if one of my patients gets COVID, they're not sick enough to be hospitalized. If they reach out to us, there is a way for us to reach out to the infectious disease team so that patient can get that monoclonal antibody to prevent severe form of the disease. Personally, I feel like those drugs have been underutilized, and I think they can really add a lot to this particular patient population.
Great, thank you, Dr. Mupidi. The follow-up question to that was, Dr. Richmond, have any studies been done on the potential side effects for immunosuppressed patients receiving one of the COVID-19 vaccines? I think you had addressed that earlier, Dr.
Yes, immunosuppression should not cause side effects from the vaccine. It just has to do with how well the body is going to make the needed antibodies that the vaccine is inducing. But so far, there has not any reduction in the antibody production after the vaccine has not been enough to be significant.
Okay, thank you.
There's actually one other thing about myasthenia and COVID, and that is, so the really serious part of COVID is getting pneumonia, affecting your lungs. And so the lungs aren't doing their job very well. And if you add to that having myasthenia, where your breathing muscles aren't working well enough, it's a bad combination. So we want to do everything we can to prevent the pneumonia caused by COVID. And that's what the monoclonal antibody and the other available treatments can do.
Okay. Thank you. Dr. Terralong, the next question is, when should we get the COVID vaccine? Are we able to choose which vaccine you receive? Or is there a specific one that we should get as having MG?
So I think I agree with Dr. Richmond that you should try to get it as early as possible. In California, everything is being run county by county. So I've had some patients with other neuromuscular diseases, for example, in Alameda County, be sent to their Department of Public Health. And then there they've been given a specific place in a queue, for example, high on the 1C group, to make sure that the second that the vaccine is available to them, they're able to get it. Different counties have been getting vaccines at different rates. So it's oftentimes based on where you work or where you live. So checking in both of those counties, if you're still working, can be helpful for seeing where you're able to get vaccinated faster. In terms of timing of the vaccine, other than as early as possible, there is one medicine for which There is some data that is suggestive that there might be a timing question, and that's if you're on a CD20 depleting therapy like Rituximab. There's in other vaccines, it's been shown that Rituximab decreases the antibody response. It's not been shown how much it might decrease it in any of the COVID vaccines, but there is some data. There's suggestions now that perhaps if you're thinking about starting Rituximab, to try to get the vaccine done beforehand with about a 4-week lead time between the second dose and the next dose, and consider being on other immune suppressants before then. In terms of which vaccines to get, almost all the vaccines that are in the queue right now are considered fine. The ones that you'd want to avoid would be the live attenuated ones, because most people here are on some form of immune suppressant. There's very few vaccines that are being developed now that are live attenuated. Neither any of the mRNA vaccines, none of AstraZeneca's vaccine, Novavax, or any of the vaccines that are even potentially coming from India have that mechanism. They're either protein-based, mRNA-based, or DNA-based. So all of those should generally be safe. And if they're available to you, you should be able to have them.
Okay, great. Any other comments? All right. This question is for Dr. Richmond. I was diagnosed with MG in 1995, although my symptoms for generalized MG are better. However, I've been struggling with double vision, which really affects my daily routine in all aspects. Eyeglasses don't work as the day passes by. Is there some type of procedure, medication that would help me with this issue?
As I understand the question, it's about the double vision.
Yes.
And not the rest of the myasthenia.
It sounds like the symptoms are better for generalized, but they're just having problems with the double vision at this point.
I see. So that's not uncommon. People are treated and everything gets better, but the last thing to get better is double vision. We can talk, I'm going to talk in the next hour about the various treatment options, and that would be one alternative, is to treat the myasthenia again and try to induce a complete remission, which is always the goal, if possible. But if that's not a good way to go, then what can you do to treat the double vision by itself? Prism eyeglasses, which change where you're looking so that it corrects for the imbalance of the two eyes. They don't work very well in myasthenia in general. In some patients they do, but in most patients with myasthenia, because the muscle weakness in these eye muscles is fluctuating with time, and the prism glasses just change things one amount. So many times the prism glasses don't work. But double vision occurs because the two eyes are not looking at the same spot. And each eye sees the image in a different place, and that's why you see double. So if you close one eye and you have double vision from myasthenia, then the double vision would go away, should go away, if it's from myasthenia. So step one, you could close one eye. Step two is you could close the eye, more permanently or for a longer period of time by putting an eye patch over the eye. Or getting the kind of glasses where one lens is sort of blocked out, so you're not looking with two eyes. Short of that, people who have double vision from other causes, they can have surgery to kind of move the eyes so that they're on the same spot. For the reason that prism glasses don't work, this frequently doesn't work in myasthenia, is sort of shortening one muscle and lining the eyes up because of the fluctuation and weakness that occurs. So yeah, those are the various options. Treating the myasthenia, wearing an eye patch, I guess that's what's open to you.
Okay. Let's see, this question is for, we're kind of trying to keep them in some kind of sense here. How long is it, this is for Dr. Muppidi, how long is it safe for an MG patient to be on prednisone, especially when the other immunosuppressants such as Celcept or Imuran are not working?
Yeah, it's a good question. I think how long is it safe depends upon individual person. I think it depends upon what problems do they have. So let's say they have bad diabetes, uncontrolled hypertension, or some other prednisone related significant side effect. It might not be appropriate to keep sticking with it. And so it is a very individualized sort of decision-making process regarding how long and what dose of prednisone to give, especially if prednisone is effective but other drugs are not effective. I will put in a plug saying that there are other treatments available beyond Imuran and Celcept, for example, for myasthenia, different monoclonal antibodies. And then there are also lots of clinical trials that are ongoing at all the 3 centers that are represented here. And so I would encourage you to sort of get another opinion about, continuing on the prednisone, participating in a clinical trial, looking at other therapy options. I'm personally, although prednisone is effective, we all see side effects from chronic prednisone use. And I personally like to minimize the dose of prednisone as soon as I possibly can once the symptoms are better, but it is sort of individualized answer.
Can I comment on that a little bit? I'm sorry I missed Dr. Muppidi's talk earlier. I totally agree with what he just said. I would frame it slightly differently. So myasthenia, like most autoimmune diseases, it builds on itself. And the idea is to turn it off, induce a remission. And as I'll mention, prednisone is probably the best thing we have for that. But there's a price to pay with the side effects. But the general idea, and I think this, I'm trying to direct it at this question. The general idea is to treat the medication, treat the disease when it's in a flare-up with high doses of, say, steroids, prednisone, and induce a remission. And that frequently takes a few months. And once there is a remission, then we want to taper the dose of prednisone down, usually fairly slowly. And in most patients, the dose can be tapered to almost zero, to a very low dose. And so the idea of staying on other than a very low dose of prednisone over a long period of time, I don't think that's a good idea. I think there's something wrong in the picture there. Either it didn't work in the first place to induce remission, and in that case, additional treatments would be needed, or the tapering hasn't been carried out correctly. But there are some patients who are, the term we use is steroid dependent. They just can't get down far enough to be on a safe dose. even if you taper the dose very slowly. And these medications you mentioned, other immunosuppressants, azathioprine or mycophenolate, they generally are most effective in helping that tapering process. They don't work all that well by themselves, but they're good in the situation where the patient has become steroid dependent. But I think the way to think of the prednisone is high doses or medium doses. You don't want to be on that for a long time, but very low doses are quite safe, and they seem to work in people who get into a remission. They work pretty well in keeping them in the remission.
Great, thank you. This is for all three of you. As a neurologist treating MG patients, what do you suggest as the best way patients can prepare for a visit with you, such as what do you like them to do when they're coming in to see you, either the first time or subsequent visits? What helps you as a care provider to treat them? And we'll start with Dr. Terlong.
I think one of the most helpful things, especially since a lot of the patients that we have are oftentimes coming in for second opinions or questions on medications, is what your initial symptoms were, how you were doing when you were at your worst, and then what therapies you've been on and what in particular got better and what didn't get better on each of those therapies, because I think that those things together kind of help point to what the next potential therapy might be and understanding which effects came from which medications. So I think having that history fleshed out is oftentimes most helpful at the beginning.
Okay, great. Dr. Mupidi?
Yeah, I agree with Dr. Terlong. I think that is probably the critical piece, especially if you've had history for of myasthenia for a period of time. It becomes very tricky if you had disease for a period of time and you've tried different drugs, and it's very difficult to sort of in retrospect recall. So I'm a big fan of folks who sort of at least document some of their symptoms over a period of time so they have a better understanding of it. One of the things that I always ask patients is which symptom disables them the most and how disabling is it for them? The reason I ask that question is because we have lots of medications available beyond prednisone, Cellular Therapy, and including various infusions, plasma exchange. All of these therapies come with potential for side effect. And I like to take the sort of the approach that I'm not going to be the person who can like judge it for a single person. How disabling is this symptom for them versus is it okay to take this one medication because it has some side effect? And so I think I usually ask patients, how bothersome is this? Because if we want to escalate therapy, that's the key question that I always ask.
Okay. Dr. Richmond, how about you? What do you like to see when patients come in to see you?
I agree with all of that. It's good for a new patient to bring their previous medical records, especially all the laboratory testing that's been done. And for returning patients, it doesn't hurt to make a little list of questions that you want to make sure you ask the doctor.
Great. Okay. Let's see. There were several more submitted questions. Jessica, were you wanting to take the ones from the chat or from the submitted ones next?
Yeah. I think we have a couple more that were submitted that we can address, and then we can go ahead and jump into the ones from the chat.
Okay.
I think the next question that was submitted was, how many patients experience weakness in their arms and legs, and what can or should the patient do about this? Dr. Richmond, if you'd like to address this one.
Well, that's a good question. Myasthenia gravis affects the muscles we usually don't think of so much as muscles. Most most often the eye muscles, so double vision and drooping eyelids are the most common symptoms. And then it affects the muscles around the face and throat. So weakness of the lips and the tongue, and swallowing problems and speaking problems. And then the breathing muscles in our chest, and least commonly the arms and legs. But it does affect the arms and legs in some patients. And I think the treatment is the same as the more common kind that's affecting the face and eye muscles. But I guess the only unusual thing about the arms and legs is that that can be a side effect of steroids, of prednisone. We frequently see that happen. Patients are treated with high doses. The myasthenia that was above the neck mainly goes into remission, and then they start having arm and leg weakness, and that turns out it's the side effect. Even more reason to taper the dose of prednisone down.
Thank you.
Can I just add one?
Yeah.
Yeah, I agree with everything that Dr. Richmond said. I think one unique thing about myasthenia that's not always appreciated in other diseases is because of the sort of the wide spectrum in manifestations, that the treatment might not be hugely different, although the degree of problem from a symptom might be different based on what the individual person does. So the classical example that we all see in our practice is that somebody just might have double vision without any weakness in their arms or legs. They're able to speak, swallow, chew normally. But let's just say that they are a professional driver, or they're a truck driver, for example. That's just profoundly disabling, but it's just in their eyes. Versus, you could have weakness in multiple muscles that doesn't allow you to do many things during the day. So, one type of weakness doesn't always supersede the other one unless you're so weak that you're hospitalized. And we all try to sort of individualize care to one patient based on their, degree of disability from the symptom.
Okay. So we're going to start getting into the questions that were submitted in the chat. If your question was not answered, we'll be sure to have it answered after the conference, and we'll send out the answers via email. So one question was, if I had a reaction to the first vaccine shot, and by reaction, they mean that it aggravated their MG symptoms and not necessarily a flu-like reaction, should I still get the second shot? Dr. Caroline, your thoughts on that?
I think that one is tricky. I'd be interested to know if that actually has happened to someone, largely because there's data from the flu vaccine showing that the flu vaccine can certainly aggravate myasthenic symptoms, but the flu itself is much, much, much worse at aggravating it. So the risk of a vaccine is still much less than the risk of getting the flu. Now that we're in a case where we have a two-shot vaccine, if you've had symptoms from the first one, my guess is that you probably would again have some symptoms from the second one, but again, that it probably would be less so than if you had COVID. I think that's still something that you'd have to discuss with your doctor, how bad those symptoms were. For example, if it was that you were having respiratory difficulty, it might change some of the calculus about how we think about doing the second shot. But if it's that your double vision was worse for a week, we might say go ahead and get the second shot. So I think some of the symptoms also matter for that.
Dr. Richmond, this question is, why does MG affect the body in cold weather?
I think that probably I'm going to talk a little bit about what the problem is in myasthenia, the connection between nerve and muscle, that it probably the weather is affecting that signaling. In a small number of patients, very hot weather seems to affect the disease as well. And I think we know that less well, the reasons for that. I'm making a continuing pitch for being in remission. It's remarkable that people who are in remission, that is, they have no symptoms, they withstand all kinds of insults. They, can have a bad infection or be hospitalized for some other issue, or, have surgery, get exposed to very cold weather, and so forth. And they seem to do pretty well. It's when the myasthenia is on the edge and you're sort of just managing with it that these outside things affect it.
Okay, thank you. Dr. Muppidi, so if a person gets COVID, can they get IVIG and a COVID shot to get better?
Yeah, so let me just say, maybe tease out the question a teeny bit, just so that I understand it right. So let's say a person got COVID and then their myasthenia became worse as a consequence of it. Can they get IVIG? Yes, they can get IVIG. That would be one way to treat the myasthenia getting worse. Now, can they get the COVID shot? So if they had COVID, they can still get the COVID shot. It is recommended that you still get the COVID shot. You might not need the COVID shot right away because your body will produce some degree of antibodies, especially if you had clinical symptoms of COVID. But if you look at the CDC guidelines, they do recommend that you still get the COVID shot when it's available, maybe a few weeks to a few months out even after having the COVID. The question is, can you get both at the same time? I mean, it might not be quite practical if you actually had COVID and you're in the hospital getting IVIG, but in general, let's just say that you have myasthenia and you're on IVIG therapy as a maintenance therapy, for example. Can you get both of them? Sure, you can. There is this theoretical concern that there might be some sort of antibody response that you get from the COVID shot somehow is affected by the IVIG. But again, if you look at the CDC, and I covered this in the earlier presentation, they don't recommend any changes in your regular regimen because we really don't know much about any interactions there.
Thank you. So Dr. Terlong, MG is on the list of rare diseases and in many instances has been hard to diagnose. How can the MG community bring more attention to this disease so that it can be diagnosed more quickly? For example, many physicians know little about it, including ER staff and first responders.
I think that's an excellent question, and it's tricky because it comes from different places have to work on trying to increase awareness. There's the increasing of awareness within medical centers that train doctors, and oftentimes myasthenia is taught in a lecture, probably in a single lecture with a lot of other diseases. And I think there's probably a lot of awareness that it exists, but in terms of remembering exactly what the identifying factors are or how it's treated is probably on the lower side. One thing that I found that can be helpful from a patient perspective is that after you've received the diagnosis, especially if you've had to go through many different physicians, is to go back and just let the other physicians that you've worked with know what your final diagnosis might have been. Sometimes that feedback can help that physician or people within the community know, oh, this is something that should probably be higher on my radar if I see another patient who looks the same. And most physicians actually enjoy getting that type of feedback because it helps them with their clinical reasoning. On the other side, I think too that within healthcare, we're doing a bit of a better job of now making sure that there's more cross-disciplinary discussion around these types of things. For example, at UCSF, we have several neuro lectures now on emergencies that occur in the emergency department, for example, like a myasthenic crisis. So people are being trained more, but again, it really, some of it has to, if from the myasthenic community, it's probably going back and letting your other providers know so that they can then have it higher on their radar.
Great, thank you. Let's see, Dr. Richmond, I think this question was brought up earlier when you were speaking about low doses of prednisone. And so a couple of people were wondering what is considered a low dose of prednisone.
Good question. So my usual goal in tapering patients is to get to 10 milligrams every other day. There was a time in the past when I tried to get patients to 0. 10 milligrams every other day is an extremely low dose. But when I tried to get patients to 0, I'd say about half of them flared up eventually, usually 3 or 4 months after getting off the medication completely. So, and I think at the 10 milligram every other day type dose, there are essentially no side effects.
Great. Okay, thank you. Let's see, so the next question, Dr. Muppidi, how well do the mRNA vaccines affect T-cell defenses? Those of us on Rituximab often do better than expected despite low B cells when fighting off viruses.
Yeah, so I don't know the answer. I don't think we quite know what happens with your immune response if you are on, other medications which can affect primarily T cells, like CellCept, for example, or Immuran. We usually think of Rituximab because I think, as Dr. Lange mentioned, there is a sort of a clear data as to the risk of viral infections and decreased antibody production with certain drugs. I don't know if it hugely affects the efficacy of the vaccine. We just don't have data because, as I mentioned in the earlier presentation, that patients who were immunosuppressed were not included in the 2 clinical trials for the Pfizer or the Moderna. The data is publicly available at least. And so we don't know regarding how much of a response those patients develop after the vaccination. From my own experience of having had my patients who've been vaccinated, I haven't had any bad outcomes so far.
And just to make everyone aware, we do have a lot of questions being submitted, so we'll take the question and answer panel up to 12 p.m. and then at 12 we'll start the next session. So let's see, Dr. Carolong, the next question. Most of the medications for MG treatments are very hard on the stomach. If you get to a point where you can't tolerate taking the medications, what are your options?
It's an interesting question because the medicine that I oftentimes, azathioprine and prednisone would probably be the 2 that in my mind would be the ones that are hardest on the stomach. And those are among the first medicines that people try in terms of first being on steroids, coming down, and then starting azathioprine to decrease more. For some of the medicines like azathioprine, I've oftentimes seen some patients say that they are nauseated at the beginning and then they don't become nauseated later on, so they adapt to it. For the prednisone, some people are placed on a PPI or a antacid medicine for the stomach, which can help, or they can time it in a way that makes it less aggravating for the stomach. Or they can also, as Dr. Richmond noted, you don't necessarily have to take it every day. Sometimes it could be spread out every other day to be able to help minimize some of those side effects too. I think if you are on one of those medicines and the side effects are starting to, including the abdominal side effects were so bothersome that it was becoming hard to continue, then that might be one indication that if you weren't able to be well controlled without those medicines, one of the infused medicines might be helpful. That are on more of the 3rd line group, such as either Rituximab or even Equilizumab. But it probably, if your symptoms were quite mild, it's a little bit tough, but it's probably symptom management at the very beginning. I don't know if Dr. Muppidi or Dr. Richmond have any other tips for that.
Agreed.
Yeah, agree.
Great. So Dr. Richmond, the next question is for you. Are there any new studies or research being done on treating Musk MG?
Musk MG?
Yes.
Yes. It's actually the area that I work on the most. So thank you for that question. So Musk MG is about 5% of patients with myasthenia, around that amount. It tends to be more severe than the standard myasthenia, and it responds perhaps a little less well to steroids, doesn't seem to respond at all to Mestinon, but it seems to respond extremely well to Rituximab. And so very much better than regular acetylcholine receptor myasthenia. So I would think, I mean, and the treatment lasts for a couple of years frequently. So I think it is there's a real place for Rituximab and Musk myasthenia.
Great, thank you.
Can I just add couple more things? I think so. Maybe this particular person who asked the question, maybe if they haven't had Rituximab, I completely agree with Dr. Richmond. They should definitely think about that with their doctor. I agree that anecdotally and by data, there is dramatic response to Rituximab in Musk MG. I just want to put it out there that there are a few other drugs in the pipeline, sort of a new class of drugs which reduce antibody levels called FcRn drugs. And some of those trials do include Musk patients. And so hopefully we'll learn more about them, but that might, if those drugs do get FDA approved, that might be another option.
Great. It's always encouraging to hear that there's new medications and treatments coming out. And so let's see, Dr. Terlong, do you know if there's any new antibody tests coming down the pipe for seronegative patients?
No, none that I've heard of that are promising or that are outside of the four main ones that we test probably the most, including like striated muscle, LRP4, and then Musk and acetylcholine. There's no other ones I've heard that have really been coming down the pipeline.
Okay, thank you. Let's see. So this question was for Dr. Muppidi. Is it possible for the body to become dependent on prednisone so that it's never possible to taper completely off?
I think Dr. Richmond was mentioning this earlier, is that if you're on steroids for a long period of time, because our body also produces steroids, those adrenal glands get suppressed and you need to be on some dose of steroid. But those patients who are dependent that way only require a small dose of steroid, not necessarily large doses of steroid, because their body is not able to make enough steroids by themselves. So there is a steroid dependency that can happen if you're on them for a long period of time. And sometimes we try to control the disease well and very gently and slowly try to reduce the dose of steroid to prevent that from happening or try to treat that from happening. But sometimes it can happen that you're not able to completely come off it. The good thing about that, if there is one good thing, is that if you're dependent on steroids, you should only be dependent on a very small dose of the steroid. Something like what Dr. Richmond said, maybe 10 milligrams every other day or between 5 to 10 milligrams a day. If you're requiring much higher doses and you're having complications from steroids, that certainly would be a reason to sort of talk to your doctor about other medications, or have all the medications been tried, because there are lots of newer medications either available or in the pipeline, so something to think about.
Great. Dr. Richmond, this question was in regards to something you mentioned earlier. So the question was, why would you prescribe 10 milligrams of prednisone every other day rather than 5 milligrams per day?
Good question. There are some data, it's probably not perfect data, that when steroids, and this is not data specific to myasthenia, but to just about any disease that steroids are being used to treat, if it's given in an every other day schedule, the side effects tend to be less than an everyday schedule. But it may not be as effective in an every other day schedule. Again, there aren't any data to really say that, but so I tend to give it every day when we're trying to induce a remission. And then when we're in the tapering process, I move to every other day because we're wanting at that stage to reduce possible side effects.
Sorry, I'm trying to.
There was a question, all three of you talk about remission. There was a question submitted that says, I have been in remission for over a year. Is there any research regarding how to hold on to that? Or is it just random luck? And really, what is remission when you're on medication? I mean, what does that term mean?
It means no symptoms.
Okay.
Or essentially no symptoms. I don't think there's good solid research data to taking 10 milligrams every other day being better than 0, but that's been my observation over the years. And so that would be one, if you're on 0, that would be one thing to consider, is to take 10 milligrams every other day. But I'm not sure if a patient came in to see me and they were on 0 and they were in remission, that I would mess with things. I think in general, people who are in remission and they stay in remission for a long time, now certainly you can have a flare-up. You know, I've seen flare-ups occur after 20 years of remission. It can happen, but the good news is generally in that situation, it's pretty easy to bring the disease back into remission.
Thank you.
One thing I would like to add is that you know, if you ask a bunch of neurologists, we'll come up with fancy words to define everything about remission, but that essentially is the correct answer. We can get all fancy with different terms, but yeah, if you're on medications, and we call it pharmacological remission, and sometimes if folks are really doing very well, sometimes we try to reduce the dose to see if they can remain in remission. One thing that I always tell my patients is that, especially those who are not having any symptoms or those who are not requiring therapy, I still tell them, you still have the disease. And so if you go somewhere and they want to give you a new medication, you have to tell them that you still have the disease. Or if somebody wants to prescribe, you need a surgery of some kind, you still have the disease. So make sure to sort of tell other physicians who are taking care of you or other things that you need, that you still have the disease. I know it's, we all would like a place to be where we can say, you know, I had that disease, I don't have it done with. I don't think we are there yet.
I think that's an important distinction, because sometimes we hear the word remission as used in cancer or some other types of things, and it might mean a little bit different than remission with MG. And So that's why I thought that was an important question that was submitted to ask. So thank you for your response.
Another question here is going back to COVID, and it's why are patients with MG not being considered for early vaccine groups? I don't know if this is a question we can answer, but Dr. Vaccine, do you have any feedback on that?
Well, the reason is that I'm not the governor of the state. I'm just kidding. I don't know. Neither do I ever want to be in any kind of office in this kind of situation. But I don't know. I think it's a valid question. I think I know those folks who make decisions don't have an easy decision to make, and I'm not trying to be funny. They make decisions on the data that they have. The reason we have the project called CARE-MG, the reason we are doing this is because we are all worried that patients with myasthenia might be at a higher risk of COVID. Patients with myasthenia might have bad outcomes with COVID. If somebody were to call me, I would strongly advocate for myasthenic patients to get early vaccination. But if you look at the current reported databases, the factor that seems to predict poor outcome or mortality seems to be old age across the spectrum. And so I can see the logic as to why they're using age as a criteria, above 75 and above 65 and so on and so forth. But there is no data saying that myasthenia itself is much more affected than some other autoimmune diseases where patients are also on immunotherapy. And so this is one of those difficult places to be in where there just isn't enough vaccine for all the high-risk people. And so, yeah.
I also suspect from looking over some of the initial data that was done, a lot of the rare diseases, if it's considered a rare disease, it's hard to make one of the risk factors whenever they're aggregating data. So a lot of the risk factors that we see are things like hypertension, diabetes, heart disease, or lung disease. And because of that, they actually did try to apply it to as many neuromuscular diseases as possible. So patients with muscular dystrophy who are known to have certain heart diseases, or even patients with motor neuron disease or ALS, which their lungs are known to be involved, they were able to be moved up. But because myasthenia doesn't affect all people across the board the same way, that disease hasn't. But if you talk to your primary care doctor when they're trying to figure out where you are in the line, if you know, for example, that your myasthenia has involved your lungs in the past, there may be ways that they can think about how you might have those risk factors that are already known to be able to move you into a higher tier. And then hopefully with some of the data that Dr. Mupidi and his group are accumulating, we'll be able to move people up faster too.
So we'll address one more question here, and there's some more specific questions that were submitted in the chat, and I'm going to do my best to get your name so we can email you an answer directly. And I'm sorry if we weren't able to address everyone's questions though. So the last question we have here is, does having MG disqualify someone from being an organ donor? Dr. Richmond?
Boy, not that I know of. I can't see why it would. Myasthenia only affects the muscles. So it may be that the medication you're taking might prevent you from doing that, but my answer is I don't really know the answer, but I don't think it would.
Okay.
Yeah, I don't think it would. I can't imagine how it would. And we are talking about scarcity of resources. I know there's scarcity of vaccine, but there is, huge scarcity of organs for those who require organ transplantation. And I can't imagine myasthenia would be any way sort of a factor that would exclude you from being in the donor group.
Okay. Awesome. Well, thank you so much, Dr. Vaccine, Dr. Carolong, and Dr. Richmond for answering all these questions. We're going to take a short 5-minute break, and then we're going to jump into the next session with Dr. Richmond on research and clinical trials. So if you want to hang tight for about 5 minutes, we'll go ahead and jump into that next session shortly here.
Thank you, doctors, so much for your participation. Had so many good questions.
Okay.
Can you see my slide?
Yes, I can, Dr. Richmond.
Okay, great.
Sorry for kind of putting you on the spot there for starting a little bit later, but we had so many questions.
No problem. I'm
Okay.
definitely available.
Okay,
The questions are always the best part.
they are. They are. Okay. One of the questions, and maybe you can address this briefly at the beginning, maybe when we introduce you on this group. We don't hear much from what's going on at the research center, you know, where we used to have the lab tours. Maybe you can talk a little bit about that and let research, because it's been about 3 or 4 years since we had a lab tour there.
Sure.
Okay.
I'll do that.
Great. Okay, so I guess we should start here. It's 12.
Yeah.
Okay, welcome everyone back to our third session of the conference here. We are going to be having Dr. David Richmond from UC Davis talk to us about research and clinical trials, kind of giving us an update on that. So I'll just, Dr. Richmond has been at UC Davis. Actually, I don't know how many years you've been there. I was going to ask you that.
You really want to know?
Yes, we do.
30 years.
Oh my
30
God.
years. Wow, that's great. And so he has been seeing lots of changes over those 30 years, I'm sure, with MG. So we'll turn the time over to him right now.
Thank you. So I'm going to talk about everything you need to know about the treatment of myasthenia. Okay, and once you know that, I think we can talk about what the future is, what the newer treatments are. So let's see. What goes wrong in myasthenia is in the connection between nerve and muscle. When we move something, our brain thinks the thought that we want to move our arm or our eye, and up here in the brain, and then the signals travel down along the nerves electrically. So it's an electric impulse comes down the nerve until it gets to the very end of the nerve. Whoops, how did that happen? Gets down to the very end of the nerve. And then the electric signal is transformed into a chemical signal at what's called a synapse. I don't really have to remember that word, but I probably will use it at the synapse. And then the chemical signal is retransformed into an electrical one. And so the brain thinks we're going to move, signal comes down electrically, synapses in the spinal cord, and then it comes to the muscle where there's a very special kind of synapse between the nerve and the muscle itself. And so blowing up this area right here, this is what the neuromuscular junction or the neuromuscular synapse looks like. Here's the end of the nerve, and it's full of these vesicles, which are packets full of acetylcholine. Acetylcholine is the neurotransmitter. And so the electrical signal gets to the end of the nerve, and that electrical signal leads to the release of the vesicles contents of, acetylcholine. And the acetylcholine travels that small gap between the nerve and the muscle. And then on the muscle, there's an acetylcholine receptor. And these receptors are on the surface of the muscle. And when acetylcholine interacts with the receptor, that starts an electrical signal in the muscle, goes up and down the muscle, and the muscle contracts. And that's how it works. And in myasthenia, we know it's an autoimmune disease, right? And these are the antibodies, these little Y-shaped molecules, and they're binding to the receptors on the muscle side and damaging those receptors. And so it leads to not enough receptors on the muscle. So even though the nerve seems to be releasing the right amount of chemical with each electrical signal, there just aren't enough receptors to receive that. And so the muscle doesn't contract as well. That's the basic problem. And that's what we're trying to get rid of. We're trying to treat. Here's a blow up of the Y-shaped antibody molecule. And it's got two arms. And these two arms at the bottom here bind to their target. In myasthenia gravis, these antibodies are directed to the acetylcholine receptors on the muscle. And they bind. And then in the back end of the molecule is the area that interacts with the rest of the immune system. And so once you get binding, this part becomes active and starts bringing in the rest of the immune system. And the most important for myasthenia, the most important part of that immune system is complement. Complement is in the blood, it's circulating, and whenever it sees an antibody that's bound to its target, it starts activating. And the complement boosts the effect of the antibody, causes much more damage than just the antibody itself. And we know that the antibodies plus complement are what is really doing the damage to the receptors. And that's what we're trying to obviate. So let's, with all that information about what's going wrong, how should we treat myasthenia? The first step is Mestinon, pyridostigmine. It has no effect on the antibody attack. But what it does do is increases the acetylcholine, that chemical that's released from the nerve. And it does that by blocking this chemical right here, ACHE, which is an enzyme sitting down here in the valleys of these folds. And what normally happens is the acetylcholine is released, it binds to the receptors, activates them, and an electric signal makes the muscle contract. And then it dribbles down here and gets broken up, removed by the acetylcholinesterase, ACHE. What pyridostigmine, Mestinon, does is it blocks this enzyme so that the acetylcholine stays around longer and beats the remaining receptors into submission. It pushes them as hard as they can go. And this is a very good treatment of myasthenia. It's pretty low side effect. It works, but it only works when you have enough remaining receptors to make a difference. And when you lose a certain amount of receptors, then it's not very effective. And then we have to turn to treatments that are attacking the antibodies. And we're usually talking about treatments with more significant side effects. So here's the list of the various treatments, the so-called immune-directed treatments. They're treatments that are aimed at decreasing the antibodies that are aimed at the acetylcholine receptors. And all the treatments we have so far, except for one, are non-specific. They affect all the antibodies in the body, the good antibodies that we need, as well as the bad myasthenia-causing antibodies. So that's our dilemma in 2021. We have treatments that are effective in reducing the myasthenia antibodies, but they also affect all the other antibodies, and they have loads of side effects. Plus they have additional side effects. So the only one that is really only affecting the bad antibodies is thymectomy. So we know that if you remove the thymus, especially when there's no tumor of the thymus, that the myasthenia will improve slowly over years, and the antibody levels will go down. And this removing the thymus gland seems to only affect the myasthenia. Someone who has a thymectomy has normal immune function otherwise. Okay, so that's thymectomy. The next level of treatment are corticosteroids, prednisone. And these steroids work by reducing the amount of antibody that's produced, but also reducing that back end of the antibodies functionality. So it has kind of a double effect. And they're very effective in myasthenia. You know, I like to talk about them as a wonder drug for myasthenia. 80% of people who get high dose steroids, 80% of patients with myasthenia go into remission. And that's the best, you know, that's the best treatment we have with statistics like that. But the problems are just the gazillion side effects. And I, you know, spend a lot of my time dealing with side effects of steroids. To some extent, you're trading one disease for another, but you can usually manage it. And as I mentioned before, the way corticosteroids work is given in high doses. They have this 80% probability of inducing a remission. Once it occurs, as I said, takes 2 to 3 months to induce the remission. Then we start to slowly taper the steroids, and it usually takes me about 18 months to go from high doses like 60 milligrams a day to the very low maintenance dose of 10 milligrams every other day. In addition to the corticosteroids, we have other immunosuppressant medications, so-called cytotoxic immunosuppressant medications like azathioprine, Mrna, mycophenolate, Cellcept, cyclophosphamide, Cytoxan, cyclosporin. They all reduce the antibody production. But for reasons that aren't clear, they're not as effective as steroids. They don't have that 80% track record. And generally, they've been relegated to being used as steroid-sparing medications. That is, help you get off the prednisone. Some people can have their prednisone dose tapered down slowly and they get to 10 milligrams every other day, no problem. But other people, they get, you know, maybe they get down to 20 milligrams a day from 60 milligrams a day, and even with slow tapering, the disease still flares up after they get to that point. Then that's the time for these other medications to be used as steroid-sparing medications to help the tapering next go around. Because two things. It's very uncommon if you go down on the steroids and there's a flare-up that you can just add one of these medications and control the flare-up. Usually you have to go back up on the steroids to the higher doses. And then once there's a remission, start slowly reducing, tapering again. But for people who have had a flare-up, they can frequently now be tapered down with these steroid-sparing medications. So that group of treatments that I just talked about are the long-term treatments. That is, they take a while to work and you need to use them for some extended period of time. We do have the two short-term treatments, plasmapheresis and intravenous immunoglobulin. Both of these also reduce the antibodies or reduce the effects of the antibodies. And they can work within a week. sometimes it takes a few weeks for them to work. And that's the good part. They work really quickly, but the bad part is they don't last, usually not more than the effect, not more than a couple months. Okay, but so what are the newer treatments and what are clinical trials? I've sort of tried to group them into particular types. The first group and the first one that was shown to be effective is Equilizumab. These are agents to reduce complement activation by the antibodies that are already bound to the receptors. They're generally reserved for patients who have very severe disease that has not responded to the usual treatments. Remember, I said 80% respond to high-dose prednisone. That still leaves 20% of people who need something more. And that's the group that complement blockers are directed at. But the downside of these complement reducing agents is that you need complement in your immune system. And complement, I think, evolved so we could kill bacteria and to some extent viruses when we get infected with them. And this booster effect of the antibody tends to totally lead to destruction of bacteria. And so if you're taking one of these blockers, then your risk of a bacterial infection is considerably increased. And it's especially, you need complement, especially for the bacteria that are like the meningitis bacteria. And in those patients that are on Equilizumab and now the newer complement blockers need to be vaccinated against meningitis. Okay, so that's the complement activators. Then there are agents that physically reduce, kind of like plasma exchange, reduce the amount of antibody that's circulating. And these are neonatal Fc receptor blockers, FcRn, and there are a number of them, and they're in clinical trials right now. And this is a very interesting type of treatment. I think it was figured out when people were trying to find out why IVIG works. And plasma exchange is pretty easy to understand. Antibodies are in the plasma, we remove the plasma, so we're going to physically remove a lot of the antibodies. But IVIG is just a pile of normal antibodies that are injected intravenously. And
grade A, I guess that would be the collective grade of the
so
27 states, but not a whole.
that directed at me, or is there just somebody not muted? The
Muted.
okay, so these so why does giving a whole bunch of normal antibodies affect the amount of myasthenia antibodies in a way that's going to be helpful to myasthenia? And it seems like it's doing that by blocking this FcRn receptor. And what this receptor does is as antibodies try to leave the circulation, it pushes them back, replaces them back into the circulation. So it keeps the antibodies at a higher level. And if you block that, then you're going to lower the antibodies. But again, these are advances, but they don't solve the problem of non-specificity. That is, reducing complement, you need complement for all your other immune functions. And with this FcRn blockade, you need your antibodies for other kinds of antibodies. You don't want their levels to go down. So we can deal with that. I mean, that's pretty much what doctors are doing. They're sort of balancing the side effects with the benefits all the time. But there's a new treatment on the horizon, which is antigen specific. And what that means is they only attack the antibodies that are causing myasthenia and leave all the rest of the antibodies untouched. And that sounds pretty exciting. It's been exciting enough for us to get involved with it. And it's a cellular therapy. It's treating people with T cells. And I don't know if people have heard about CAR T cells. These are engineered T cells that have been very effective in leukemias and some other cancers. And the treatment involves taking the patient's lymphocytes, and in particular their T cells, and removing them, and in the laboratory engineering them so that they have a receptor on the T cell that attacks the cancer cell, directed to the cancer cell. Well, this is now being applied to autoimmune diseases. Take the patient's own T cells, engineer them so that the T cells will attack the cells that are producing the myasthenia antibodies, and only those cells. Just if this were a class, I'd ask, does anyone know what cells produce antibodies? Well, the answer are the B cells. So B cells make antibodies. And they're being targeted, only the myasthenic B cells are being targeted by the CAR T cells. So I'm optimistic that other problems won't appear as a result of this, but that we would now have some antigen-specific treatment where we wouldn't really have to worry very much about the immunologic side effects. So I think that's what I have to tell you about the future of treatment in myasthenia. I guess we're ready for questions.
Sorry, let me unmute myself there. That is very exciting. Thank you so much for that. I'm just looking through here on some of the questions here. I actually have a question regarding that, the new treatment with the CAR T cells. Where is that in the pipeline as far, are they doing clinical trials now? Are they in, what stage are we in that?
So this discovery, I would say, to take the cancer-related CAR T cells and try to direct them at the bad B cells was made, 5 or 6 years ago, using an animal model of an autoimmune disease called pemphigus. It's a skin disease, but very severe and quite deadly skin disease. when we heard about it in Davis, we began to think that myasthenia would really be a good disease for this type of treatment, and especially Musk myasthenia. So we've had an animal model of Musk myasthenia, and we've been developing this type of treatment in animals, rats in particular, to see how effective it is, and mainly to look for unexpected side effects that could occur. As I mentioned, the original discovery was 5 or 6 years ago in this animal model of pemphigus. Well, that work has continued, and in the last 6 months or so, they've begun a phase 1 clinical trial in human patients with pemphigus. So we're quite optimistic that there's going to be a lot of information developed in this clinical trial, and I would estimate that, maybe in 2 years, 2.5 years, it could be a treatment available to pemphigus patients. And we're hoping to sort of piggyback on that and have it in a clinical trial in Musk myasthenia. Now, the reason we chose Musk myasthenia is that Musk, we didn't talk about Musk myasthenia at all today, except, well, let me go back. I can probably say something here. Maybe I can go back. Okay. So this is the muscle, and we've got all these acetylcholine receptors here, but in addition, there is Musk sitting around the acetylcholine receptors. And so when someone develops Musk myasthenia, they have antibodies to Musk, and the antibodies damage the Musk. But complement doesn't work in this situation, and so you don't get the tremendous damage that you get with acetylcholine receptor myasthenia. But it's enough damage to cause a pretty severe disease. But if you look at the picture here, acetylcholine receptor is this big hunking molecule. Musk is a much smaller molecule. And in making these CAR T cells, you need to put Musk or acetylcholine receptor on the surface of the T cell so it'll target the B cells. And Musk is just the right size. It's the same size as the antigen in pemphigus. So it's the next logical step. But of course, what we're really aiming for is treating acetylcholine receptor myasthenia. And if it can work, if this treatment can work in Musk myasthenia, then we can take some sliver of the acetylcholine receptor and put it on the CAR T cells instead of the whole molecule, because it's too big to use. And that's another level of research that's going to have to go on. So when would this treatment be available for myasthenia gravis patients? I think it's a reasonable possibility that in Musk myasthenics, it could be 5 years from now. In acetylcholine receptor myasthenia, we're probably talking about 8 to 10 years is my guess. Although things, I think, when they really get rolling, can go faster than you think.
That is great news. I remember when you use you called, I can't remember how to say it, Equilizumab. We call it Solaris, that's the trade name, right, or the brand name.
Right.
I remember hearing about that about 4 or 5 years ago, I believe at one of the meetings that you talked about. The question here kind of piggybacks on that. Many people with autoimmune disease will end up having more than one autoimmune disease eventually. With the CAR T-cell therapy, how would you think about using this type of therapy in a patient with not just MG, but multiple autoimmune diseases?
I think you'd have to make CAR T cells for each one of the diseases. That brings up a very interesting question. Why do some people have a lot of different autoimmune diseases? There's something else going on, that their immune system is susceptible to attacking itself, and probably those patients are, the ultimate treatment for that situation is to get the immune system back under control, back in balance, so it stops doing that kind of thing. And that's probably a whole different area from what we've been talking about.
Okay. There's another question here that says, if remission is achieved through prednisone, should Mestinon and Celcept be continued?
Okay, well, so you all should know the answer from everything I've told you. So Mestinon, if the myasthenia is really under control and you're not damaging your receptors anymore, then you probably don't need Mestinon. And we find when people go into remission, they actually, they have more side effects from the Mestinon than they did before. It's something pretty interesting. And normal people who take Mestinon have many more of the gastrointestinal side effects than myasthenics. So that's the answer to the Mestinon question. And if you're not quite in remission, if you still have a little bit of symptoms, then Mestinon there may be a role for it. Now, the Celcept mycophenolate question is a good one. Are you in remission because of the combination of the dose of prednisone you're still on and the Celcept added to it? And it's, you can't know that. You can only, what we generally do is, once you're down to low doses of prednisone, like 10 milligrams every other day, or even 10 milligrams every day, the risks of prednisone are very low. And now the risks of Celcept are higher. With high dose prednisone, Celcept or azathioprine are less risky than high dose prednisone. But when you're down to low doses of prednisone, then these other medications become the riskier of the pair, and we try to reduce those medications slowly as well.
Jessica, you were going to ask a question next, I think.
Yeah, so we had a question that was submitted about clinical trials. So the question is, we often hear about clinical trials for MG treatment. How safe are those trials, or how safe are the trials for those with generalized MG? As physicians, would you encourage someone with stable MG to participate in a clinical trial?
So there are many different clinical trials, and they're in different stages. I think the COVID vaccine has educated us about clinical trials. So when a drug is first tested, it's a phase 1 test, and it's done in a small number of people just to see if there are any toxicities, any bad effects. And then there's a phase 2 where you're still trying to collect information about what could be bad about it, but you're also getting a little information over whether it works or not. And then phase 3 trials where it seems that safety is pretty good, and you want to look at how effective it is. And you can join any phase. You can join a phase 1, a phase 2, or a phase 3 trial. Obviously, phase 1, you have to have a lot of altruistic intention to get involved at that very early stage. But in phase 3, it's reasonable, and each study is looking at a different situation. Some may be looking at patients that are in remission, and some may look at patients who are having a lot of symptoms, and they all vary.
Dr. Richmond, that brings up a question of how do you find the trials to participate in? Do you have to do that through your doctor? I know there are some websites, but if you're interested in doing that, how do you go about that?
I think probably the best way is to go to clinicaltrials.gov, that website. And I think it asks what disease you're looking at. You type in myasthenia gravis, and it gives you all the clinical trials in the US. And once you've looked at that, then you could bring that information to your doctor and ask them what they think about that.
Okay.
I think that's probably the best way to do it. There are some clinical trials where I think they're just not giving a treatment, but taking blood tests and so forth. Those obviously don't really have any risk. You're not going to be changing your treatment. And that's probably worth doing.
Okay. Do you see any other questions, Jessica? Oh, here's one about, are clinical trials encouraged for general MG, even if the patient is 78 years old?
So all of these trials have age limits,
Okay.
between blip and blop age. And I think if they include you in that age, then I think it's that's been factored in, and it's probably a reasonable thing to become involved in.
Okay, for those of you, Mike Antonellis just listed the website for clinical trials on the MGFA website, where you can go if you are interested in that, on the chat. And you can also find it on the website. Any other questions, Jessica, before I think we're gonna wrap up here at this point and maybe take a break for about 10 minutes, right? Before we start the next session.
Yeah, so just one more quick question, and then some of these other questions that were submitted, we'll have them answered and send out the responses. So just one more question for Dr. Richmond. It says Alexion is testing a new, more effective Solaris. Do you know how soon this drug will be available?
No, I don't. But that may be a clinical trial someone could join. I mean, I think the clinical trial is still going on, but I don't know, when they expect that trial will be completed. And of course, like any clinical trial, you don't know that it's going to turn out positive or not.
Right.
The thing about most clinical trials is there 2 different treatments are given. Sometimes one of them may be placebo, or one might be sort of your standard treatment. And the other is the drug they're testing. and it's all blinded to carry out a clinical trial, neither the doctors or the patients are supposed to know what they're on. So there's, and this was true in the COVID vaccination situation, that, you know, a number of months went by before they figured out who was getting what and could answer whether it was effective or not.
Okay. All right. Thank you so much, Dr. Richmond, for your participation today. We so appreciated it. It's been wonderful to learn about general or just MG in your session, and then how that relates to treatments and these clinical trials. We're going to take about a 10-minute break. We'll join back up at 12:50. I mean at 12:50. And so take grab something to eat, stretch your legs a bit, and then we'll come back on at 12:50. So thank you, everyone. And thank you again, Dr. Richmond and Dr. Mupidi and Dr. Terralong.
So long.
All right, bye-bye.
Take care. Yeah, very well done. So.
love it. It's very refreshing.
Okay, so it's 12:50 now, so we'll go ahead and jump into our next presentation. I'm really excited to present Corey Farstein. We actually went to high school together, and we reconnected this past year at our 10-year virtual reunion. And so I think it's really important to hear from people outside of the myasthenia space. I think we have a lot to learn about, our bodies and that kind of thing. And we can learn a lot outside of MG. So Corey has a very interesting, very particular area of study, and so I'll let her kind of explain. And all.
Cut out a little bit there, Jessica.
Oh, Corey, go ahead and introduce yourself and
Okay.
tell us.
Can you all hear me?
Yeah.
Yes.
Okay. Hi, I'm Corey. It's so nice to be with you all. I am not going to lie to you. I am used to teaching to people in person, aren't we all? And then even when I conduct movement sessions, I usually see everybody. So I'm like craving the ability to read your bodies and faces. How are you? Is that a question we ask anymore? Somebody's asking to be admitted. I'm going to admit them. So, oh yes, we have more faces popping on. I love it. I live for it. Connection. Okay. So yes, Jessica asked me to come here today and speak. I am a fascial stretch therapist, contemporary Pilates instructor. I'm certified in a brain-based movement curriculum called Z Health. And my practice has kind of evolved over time as I've come up against different limitations in my own self and in everybody's different embodiment experiences. So I like to start by contextualizing myself. So I contextualize myself as a movement facilitator, and I contextualize you as the authority of your body. And this is really important to me, especially in the healing process or in the cultivation of resilience, which is that I don't often know if our autonomy is cultivated. So that's number one. I'm coming to you today very humbly, acknowledging that the things that you experience in your bodies are very personal to you. With regards to the subject of stress management, there is sorry, I had so much to say, and now I need to ground myself. Let's start with an experience. So you take 20,000 breaths per day, approximately, every person. And so the quality of that movement matters. It's an autonomic thing that happens without us consciously doing it, and yet it is also trainable. Enter, submit. So I'm going to invite you to have an experience with me. If you would like to lay on the ground, that is welcome. It's a normal thing that I lead people through. If you want to stay seated, that's also just fine. If you are seated, you're going to scoot to the edge of your chair. And you are going to locate your feet on the floor. If you have a hard time sensing your body in space, being able to sense where your feet are without looking at them, I'd like you to go ahead and look at them. Look down at your feet and consider fixating on them for a moment. Are you able to notice whether you have more weight on the outside or the inside? Even asking yourselves these questions matters.
The Pillow Factory.
Even being able to assess what's going on inside of us on purpose builds something called interoception, which is linked to our sense of self and is also linked in studies to lowering our propensity for stress, OCD, eating disorder, body dysmorphia, etc. So we're looking down at our feet. Even just the act of looking at them can matter. Whether or not we can actually assess whether we have more weight here or there is not necessarily the point, especially if that question in and of itself is frustrating. So if that type of assessment is frustrating to you, what I'd like you to do instead is consider pushing your toes into the floor. Do you have that ability? I don't know where that sound is coming from.
You didn't know that's what we were making today, did you? Now that's
I'm just going to mute that for a second. Okay. So you're probably wearing shoes. You might be wearing shoes right now, and that's okay. I'm the only weird barefoot one. And you're going to attempt to push your toes into the floor. That's it. Whether it's the floor or your shoes, it doesn't matter. And then you're going to attempt to let your toes soften. Even asking ourselves these questions and considering whether we have the control or the ability to connect in that way matters. Go ahead and repeat that a couple of times. Whether or not you're pressing into the floor in a way that feels really controlled doesn't matter. Go ahead and release that pressure if you haven't. What you're cultivating here is the ability to change textures. There's always an option to change the texture of your movement, especially when you don't always have autonomy over that ability. It's important to know the ways at which you could adapt. So for example, our feet are on the floor here, and we're considering what we can do with our toes, differentiating. We're going to change the idea now, and we're going to really pay attention to the floor itself. And we're going to feel that the floor is holding our feet up. And we're going to imagine pressing deeper down into the floor with our feet. This is an example of using proprioceptive feedback, something external to give us information into our bodies. From there, I want you to take your hands and place them onto your hip bones. If you can't feel your bones, that's okay. That's really not the point. But see if you can attempt and approximate. You are going to, with your hands, you're going to press in on yourself. This is another version of giving yourself a proprioceptive input through your tactile system. So you're pressing in and you're cultivating a sense of containment. For some nervous systems, this can be really, really calming, similar to a weighted blanket. With your own hands, you're going to direct your pelvis into what's called an anterior tilt. Your pubic bone will start to dip forward, and then you'll start to allow your hands to guide your pelvis in the other direction. Good, and repeat that. Moving your pelvis forward and then underneath you. Yeah. And we are not at this point going to worry about what else is happening inside your body. We're not going to worry about the texture of the movement. We're just going to invite ourselves to experience the ability to create that movement at all. Do this 1 or 2 more times. And then find yourself on the front edge of your sitting bones. Those are the bones that you sit on. If you can't feel them, that's okay. We're going to close our eyes and we're going to trust that they're there. And we're going to feel ourselves actually allowing weight into our pelvis. Awesome. From there, we're going to take our hands off of our hips. We'll flutter our eyes open. We're going to take our hand, if it's possible for us, to C7. Just find the vertebrae that feels most prominent at the base of your neck. Awesome. You're going to lift up through your skull, away from the hand that's touching your spine. Start to create decompression through your own lifting and connection to the imagery. Good. If that connection isn't there for you, that's no problem. It's for whoever it is accessible to. Lower your hand unless you enjoy it being there. As you feel this lifting through the spine and through the base of the skull, I want you then to locate the sides of your ribs. You're going to place your hands against your rib cage. You're going to press in on your ribs if you would like more feedback. You are going to take an inhale through your nose, and you are going to assess whether your rib cage moves or not at the base of the ribs, and then exhale. And repeat this if you can. Inhale through your nose. Our tongue is relaxed. Our gaze is softening, and we exhale through our nose. Good. Repeat just like this. Conscious breathing shows up in many different modalities as far as a way to regulate our nervous system. We're going to do that one more time. Good. I want you to assess whether you felt that one rib was able to move more than another. If you weren't able to assess that, you'll do both sides and it's no problem. You're going to lift up through C7 again. You're going to come to the edge of your sitting bones. You're going to start to lift up and over away from your sitting bones to one side. You're going to pause there and you're going to inhale into that opposite side of your rib. And you're going to exhale. You're going to repeat that. Inhale and exhale. Do that one more time. And exhale. Good. Allow yourself to float center. Pause here, close your eyes for a moment, reset. Every body is different. What causes your threat response to go up can really vary. So in a room full of many different people, that could have been a very threatening thing to your body. Some it might have been calming. For today, we're going to go up and over to the other side. You're going to lift through C7 first. Find a sense of space, tip. It's not so much about how far you can go. It's about bringing yourself up and off of the midline. And then we're going to breathe into that opposite side. We're going to inhale into that side of your rib, creating space in between each rib through the inhalation. And you're going to exhale. You're going to repeat that 2 more times at your own pace. Good. And then return center. Beautiful. From there, you're going to take your thumb, your hands, you're going to create a fist. You're going to place your hands against your thighs. You're going to press down through your thighs, and you're going to lift up again through C7. Collarbones radiating wide. You're going to inhale from there, and you're going to see if you can allow for this closed chain, meaning this connected hand to thigh. Our hands are not out in space, but they're connected down. Seeing if this closed chain can help restrict the breath from going up into our scalenes, up into our neck, up into the muscles that are conditioned under threat response. From there, we'll inhale through our nose, and we'll feel our diaphragm lowering down, our pelvic floor softening, and we'll exhale, and the diaphragm will rise back up. And you'll do this again. You'll inhale through your nose. The ribs will move laterally, And if the ribs move laterally, we know the diaphragm is descending. And you're going to exhale. The diaphragm will naturally rise back up inside of you. And it will naturally drag your deep abdominals, your psoas, and your pelvic floor with it. We will do that one more time. You'll inhale. And you'll exhale. Good. You're going to take your palms in front of you. You're going to create a little bit of a fire. Good. And you're going to close your eyes and you're going to place your hands on your head, on your eyes, excuse me. Now, for those of us who may have vestibular issues or visual issues, this can either be relieving or stressful. It really is different depending on the body and the nervous system. If this feels relieving to you, then sensory deprivation is something that can help to regulate your system. With your hands on your eyes, you have a few options. You can start to nod your head down and nod it up, and nod it down, and nod it up. You might enjoy nodding it from side to side. Yeah. The experience you're having in your body is the thing that matters. Beautiful. From there, you're going to take your fingers and run them through your hair if that's an accessible thing to you. If it's not an accessible thing to you, there's always other options. You are pulling on the hair and you're moving through the scalp. You're going to find yourself moving through the base of the skull. And you're going to locate your occipital ridge, the base of your skull. There's these little muscles that live underneath there. And you're going to, you have a couple different options. As always, you're going to either pull up from there with your fingers, creating this sensation of decompression. Or you're going to start to move from side to side with your fingers. And as you move from side to side, you are underneath the base of the skull. You're going to allow your eyeballs themselves to move from right to left. Yeah. Your eyes can move from right to left or up and down. Awesome. Allow that to let go. Beautiful. You're going to, from there, take your right hand, move it forward. Awesome. You are going to look at your hand, and if you have trouble with controlling movement in your hand, maybe what you do is look at it and you imagine this movement. Maybe you don't physically do it. Other options are to touch the knuckle of your pointer finger and to move your pointer finger from right to left. And the idea is that you're not moving the other fingers. Awesome. Another helpful input would be to hold the other fingers and move this one in isolation. Again, if that is more stressful than it is interesting, it's either something that you skip or something you simply imagine. Good. From there, you're going to move that finger forward and back. Awesome. And then you're going to start to stir the finger in a circle. If the circle is where I lost you, you go back and you just do what was accessible to you. Good. And then go to the next finger. Now that you know what we're up to, we're going to go a little bit faster. You're moving your middle finger in isolation. Side to side, front to back. And then circle. Go to the next finger. There are always options. The laughter. This one always gets us. You're like, I didn't know this was a thing. And then I also didn't know it was a thing that felt like this. Go to the next finger when you're ready. So your brain thinks very highly of your hands. There's an image called the homunculus, which you may have been exposed to. If not, we can Google it after. That shows basically the sensory map and the motor map that your brain has of your body. Your hands are massive. Once you've gone to the next finger, you're going to take your thumb and you're going to bring it across and then open. Good. So if your brain thinks very highly of your hands, I think it matters to us that we have a sense of autonomy over them. And if we don't, there's something amazing called a concept called opposing joints. I'm going to keep talking and keep moving you. From here, you're going to take your hand into a flexed position. I'm going to have you grab your wrist and I'm going to have you take your pointer finger down and I'm going to have you bring your hand straight down until you get this feeling of stretch in the middle of your hand. You're going to roll it up and you're going to roll it forward. Love it. Good. Repeat that. Down, around, and forward. So your brain conceptualizes of your body in opposing joints as well. So if you ever had an issue with your hand, you could start moving your left foot, right hand, left foot. You're going to leave that exercise. I'm going to keep jabbering. You're going to take now, we'll do a neck stretch because for most of us, if stress is high, which it is right now, we tend to have a constant threat response, and a threat response has a constant body shape. One of those things can be really tight scalenes. And we're gonna take our hand forward. We've touched our occipital ridge already. We're going to draw the occipital ridge back. We've done amazing things to bring consciousness to our hand. We're going to glide our hand forward in space. So we're creating this opposition between the base of our skull. Our shoulder blade is gently depressing down our back and forward. Good. If that feels too threatening, you just ditch it. From there, you're going to tuck your chin and tip your left ear away from your right shoulder. You're going to take your nose up to the right diagonal. Your gaze is going to go with you. You're going to pause there and you're going to shake your head slightly no and slightly yes. The goal is not to shock the body. The goal is to give it minimal effective dose, just enough. From there, you're going to come center. And I want you to take a reset. There's a lot of ways to reset. The way we'll do it now is by taking our fingers right underneath the base of our eyes, right inside of that ridge. You're like, what ridge? So right inside of your eye socket, ever so slightly, you'll press, you'll close your eyes, and you'll draw a tiny little circle there. If that doesn't feel accessible to you, you can also press into the middle edge of the eyes. If that doesn't feel accessible to you, you can close the eyes and press on top of the lids. As you're doing this, I want you to notice whether you're allowing yourself a full exhale or if you found yourself stuck in inhalation. We're going to do the other side of that. Flutter your eyes open, bring your hand forward, touch the knuckle of your pointer finger, and move your pointer finger side to side and then front to back. Good. And then you'll go to the next finger. And then the fourth finger. I can't tell who is who, but I see someone just like, I'm gonna get around. I am going on this roller coaster, okay? You cannot stop me. She's like, you think you can do it slow? Watch this. And then go to the next finger when you're ready. These are literally tiny, tiny pieces of an entire bag of options and tools, of ways to be in your body and to move. She's like, I'm done with that. Go ahead and take your hand forward and bring your pointer finger down. And you're gonna find that stretch through the hand. And you're gonna roll up and you're gonna roll forward. Stress is 3D, pain is 3D. Pain science itself tells us that there are biological, social, and psychological elements as to how we get into pain cycle and how we get stuck in pain cycle. Stress can be the exact same thing. There are moments where our bucket gets so full and our nervous systems are so stuck in sympathetic. And in those moments, it matters that we have tools to downregulate. Downregulating can be things like stimulating your vagus nerve, which can happen through gargling, which can happen through intentional breathing, the movement of the diaphragm. There are so many different tools for that. But then the idea is also that as you train your movement in a consistent way, that we keep at bay some of the factors that might bring your bucket to overflow. And especially when you're in, it's training for resiliency rather than the term management. And this matters, metaphor matters as well. The metaphor that we use for our bodies and for our experience has an effect on the experiences of our sensations. Even in the matrix of when pain goes off in your brain, multiple areas light up, including memory, where your brain is going, have I experienced this before? How bad was it? How bad is it or not bad is it in comparison to this other time that I felt that? And your loop gets stronger and stronger every time you come up against the same thing. So how do we allow ourselves to integrate new inputs? To me, that's what movement is. You're always moving. Your body reflects the things that you do already. And there are so many reasons that keep many people away from having a relationship to movement and to their bodies. And my simple encouragement today is that there really are always options. There really are always options. Even things like doing somatic work where you're asking yourselves questions, where someone's leading you through breath and through sensation, helps to build that muscle so that when you're at the 10 out of 10, you're made of some of the stuff that's able to say, okay, this isn't necessarily the moment that I do this, but I know myself, and this is the moment where I do this. I know there's a way to break the matrix. And it's beautiful and it's complex and it's unfolding, but it's also that there are real concrete ways of cultivating autonomy, even in a body that does not feel autonomous or in control. Yeah, and I think that's what's come up for today for me.
Thank you, Corey. Does anyone have any questions or anything they want to ask her? And I think, Corey, do you lead classes also? I think I saw on your website.
Yeah,
Yeah,
I work with people one-on-one and in class. Mhm.
Great. Yeah, so if this is something,
Where are the classes at?
Sorry, what did you say?
we can go ahead and
Where
I
are
want to
the
go ahead and
classes?
put the link to your website for your
Oh,
classes.
yeah.
Sure, yeah. They're online, Jackie. I think that's Jackie asking that question.
Yeah.
Awesome.
Yeah, so we'll go ahead and we'll include a link to Corey's website. And if this is something that you felt resonated with you, then definitely check out more of what she does. Okay. So Joy, do we want to take a small break and then we'll go into speaking with each other?
Yeah, is everybody feeling like we need to take a break before that, or do we just want to move into it, or what time? Let's see. Oh yeah, we're supposed to go till about, okay, we'll do a break till about 1:30.
1:30? Okay.
Yeah, and then what we're going to do in this last session is just those of you that are new to MGFA or newly diagnosed or want to get connected with a group. If you haven't been connected with a group before, we'll just share for a few minutes and then we'll end the program. Right? Anything else, Jessica?
No, I think that's it.
Yeah. Okay, so we'll come back in about yeah, at 1:30. Okay.
Mm-hmm. Okay. 1:30.
Are we able to mute Jackie? Let me see.
Monterrey.
Okay. All right, everyone. It's 1:30. So I think at this point, you've pretty much been muted most of the time. And so I don't want to have everybody unmute at the same time. But this is kind of a sharing time. We would like to, maybe Jessica and I could each take a few minutes and explain about our support groups. I know that many of you are not in California, but our support groups right now are on Zoom, and we are meeting on a regular basis, and anyone is really able to join any of them. But we could do that, and then just let you know, and we'll put, well, both of our names and our contact information is on the MGFA website. So you're able to contact us through that too. But so Jessica, want to just explain about yours and when you meet?
Yeah, so I lead the group in San Francisco. We started the group at the end of 2019. And so we only got to meet in person a couple times before COVID, unfortunately, but we definitely have been meeting virtually. We've been combining at times with joint groups, and we've been doing share and care sessions, and then we also hope to incorporate some more of the great neurologists and speakers that we've heard from today and that we've been connecting with in the future as well. I also work with a couple other of the MGFA patient groups. So I also work with the Myasthenia Advocacy for Young Adults group. That group is open to those with myasthenia between the ages of 18 and 40. And we're going to be having actually a meeting next Saturday, the 27th. So if that's something that you're interested in, we would love to have you. The group is more geared towards topics for young adults, but we're welcome for anyone to join. And then I'm also a part, I help lead the MG walk, the local walk here. And so, you know, fingers crossed that we can have an in-person walk later. That's something that we hope to have coming in the near future.
Great, thanks. As Jessica said, we have been combining our two groups a little bit the last 9 months. I generally have my meetings in January, April, July, and October. So we will have a meeting coming up in April, and it will still be on Zoom. And so I do the Sacramento, Central Valley kind of area. I live in Stockton, California. And so we have a lot of people from that general area, and then some that from as far away as Fresno on our group. We meet on Saturday afternoons at about 1 o'clock. And it's usually the third Saturday of the month. And we'll keep to that schedule. So, and again, anybody that wants to join any of our groups, you can find our schedule on the MGFA website. So now we just kind of open it a little bit. Is there anyone who's new to this MG community that's newly diagnosed that might like to share or ask some questions? This is your time.
Yes.
Whoops. Is that Marlon Bourne? Is that?
Yes, I'm Linda. How you doing this evening?
We're all great. Thank you for joining us.
Yes, ma'am. No problem. This is my first time coming on, and I've been dealing with it now for 4 years, and it's like it's no support. I'm out here in Virginia, and it's no support groups. I know a lot of people that's like younger than I am. I'm only 36, and it's a lot of people that goes through with myasthenia gravis, but they don't have nobody to talk to, nobody to look up to, nobody just to say, hey, you got it, you're going to be all right, you're going to make it through. just to be strong. And we need something like that out here because I know myself, I have a great supportive family, but to go through this with, like, it really bothers me now because it's winter time over here, and it really bothers with my arms and my legs that I can't walk and I can't drive and go to where I want to go to. But it's just, it's hard. It's hard to go through it, but I just thank my family for helping me. Like, but it's very difficult.
Marlon, there may be some, and maybe Dova.
Oh, excuse me. You could call me Linda. That's my son's name.
Oh, okay. I'm sorry.
He's
Because
watching
it's on the
TV.
screen.
He probably watching TV in the background.
Yeah. So I'm gonna have you mute yourself a little bit while we talk, okay? And then, yeah, it's a little bit noisy back there, but Dova, if you're able to share with her, it seems like we have a group in Virginia, don't we?
We do. I just put the link into the chat for the website for where you can see the groups in Virginia. So there may not be any scheduled right now, but we do have leaders and groups in Virginia, and you could contact those leaders or the leader that's nearest to you and see if they have any plans to do a virtual group. Eventually we'll get back to in-person groups, but until we, hear from our medical advisory board that it's safe to meet, we're going to hold off. So any of those, you can join like you did today. You're welcome to join any of our support groups. So being virtual now is a help because you don't have to be stuck with only your community. You can really reach out to many people. So I put the link into the chat for the Virginia groups. Do you see where it is?
Yes, I see where it is. I thank you so much.
You're very welcome.
And again, as she said,
yeah.
Oh, go ahead, Jessica.
Oh, I was going to say, we'd love to have you next weekend as well if you're free in the young adult groups. There's a lot of other people around your age that you can definitely share and talk with that might be beneficial for you.
Okay. Yes, ma'am. Thank you so much, because these support groups, they really needed a.
I was going to say too, oh, sorry, I didn't want to cut it off there.
Yeah, I think she got, we lost your audio. There you go. Okay. So is it Deborah? Is that who you were? Deborah, were you speaking?
Yes, I was just gonna, thank you, Ethan, pause that please. Sorry, my son's on the TV in the background. I was gonna say too, I'm on Clubhouse now, and I've been finding more and more people with similar types of disorders. So especially for the younger people, if they're interested, let them know, and we can start some Clubhouse groups or Slack channels as well too for support groups, just as additional to the regular support group you guys already provide, just additional times in between your meetings.
Great, thank you. Anyone else? Donna?
Yes, I'm in Kansas City, Missouri area, and the Kansas City MGA has online support groups for young people. Usually they meet in person, but now they do. So it's mgakc.org.
Great, thank you for sharing that with us. Jackie, were you wanting to ask a question? Jackie Lachney? You're muted.
Yes. Yes, I was diagnosed about more than 4 years ago about Lambert-Eaton, and they think that it seems it's very similar than MG.
Yes, it is similar. At first they thought it was a form of MG, but I think now they're saying that it's kind of a separate diagnosis altogether.
Mm-hmm. I see. Well, do everybody feel kind of like falling down?
I personally don't know anyone with Lambert-Eaton, so I can't answer that. So anyone else have an experience with that? Okay.
I wonder if I can go to their website and find out more about this, or
I'm sure you could, and actually we'll, between Jessica and I, we can reach out to those 3 doctors that were on today with us and see if they have some more information on that for you.
okay, thank you. Well, I'm in Gold area. Anybody live very close to Sacramento? I am probably
That's
20
me.
minutes.
I'll do that.
Okay, yeah, thank you. Thank you.
Okay. Anyone else?
Yes, Joy. Can you
Hi,
hear me?
Bob. How are you?
I'm doing pretty good, thank you. I got a late start. I have a question. You keep talking about in remission. I have had this MG for 12 years now. I'm 90 and a half years old, so I'm not quite as sharp as I used to be. But when you say remission, I have I get the Ivig shot or
Infusion?
infusion once a month, and I take all the other drugs and things, and I really don't seem to have a problem with MG. Now, is that what you're calling remission?
Well, I think what all 3 doctors actually said was that remission for MG means that you do not have symptoms when you're on medication. Is that Jessica, what you heard him to say?
Yeah.
Yeah, I mean, if you're symptom free, but you're on medication, then you're in remission. It's different than what I think the world thinks of as remission. It means absence of disease. People that have cancer, they might be in remission and they're cancer free, or, maybe they're not on medication. But with myasthenia, if you are symptom free, according to these 3 doctors, even though you're on medication, then you're in a remission. You still have the disease, but your symptoms are managed and you don't have the weakness or whatever it was that was the problem with MG. They consider you in remission. Does that help, Bob? You're on mute, Bob. Can we get him unmuted there? Bob, you're on, there you go.
Okay, I guess I'm in remission then. But however, I still feel like I have the MG. But with this, with this virus, the MG symptoms have come back. Oh, what's happening to me getting unmuted?
You're muted again.
Joy, hi.
Yeah.
Can I just say something about the remission? Being on permanent disability, I think also we need to really know the verbiage, because some of these judges won't keep us on disability. When you, my knowledge is that when you're on remission and you're still taking medication but you have no symptoms, it's technically verbiage as clinical remission. That means that you still need to take medication for you not to have any symptoms. Now there are people that are on remission, like the word just remission, but they don't take any medication and they don't have any symptoms. So that's remission. It's kind of like when people have cancer and they're like, oh, they're on remission, that means there's no showing of the cancer around there and they don't have any symptoms or anything like that. So I think the gentleman that was just speaking, because he's still on medication, but he doesn't have no symptoms, so he's on clinical remission. Just
yeah, thank you, Leah.
No
I just want to shout out Leah. She leads the new Spanish, all in Spanish MG support group. Super awesome. So if you're
a
interested in that,
Spanish group. I didn't know
Yeah.
that. Hello.
We just started.
¿Cómo están?
Bien, gracias. So
¿De
we
qué
just
parte
started.
están?
We're gonna start on. I'm gonna put my email down on the chat, and anybody wants to reach me, we're gonna have our group, our second meeting in March, and we're gonna have a doctor that will speak in Spanish and explain more about MG and any questions you have. So, and then if you guys have not only yourselves but friends or family that want to know more about MG, I really recommend reach out to the support groups, because us as MG patients, after a while, we're just like, we're done, Google it. We don't want to explain it no more. So it's just a recommendation. I always recommend these support groups for friends and family, physicians or nurses or anybody that wants to know about this wonderful, rare, invisible disease.
Oh, sí. De seguro.
Thank you, Leah. I appreciate both those comments about your group. And then I like the term clinical remission. I think that helps to differentiate between the word remission.
Well,
certainly what we suggest that you always do is get with your doctor and talk to him or her as to far as if they feel that you're in remission. And whether you're taking medication or not, and you're not having symptoms, I mean, the goal of all of treatment is to get to where you don't have symptoms. Again, it doesn't mean the disease has gone away. I've been, I guess, in clinical remission for 8 years, but it doesn't mean that I can't have a flare-up again. And I did once in that period of time. But so, Bob, I hope that answers your question. I don't know if
well, I right now, I'm having the myasthenia or the MG problems.
And I would say you're not in remission then.
And right now I'm definitely not in remission, but I was wondering if that had anything to do with the virus.
Did you have the virus?
I had the virus. It's been I've taken the pill, the stuff that stops it.
Okay, I would ask you to ask your doctor that. I don't know how we could answer that. Yes, maybe, but I think that you need to talk with your doctor about whether he feels your symptoms were exacerbated by having COVID or not. And again, anybody that's had COVID, the variety of length of time that it's taken them to recover, whether you have MG or not. I know some people that had it and they're still feeling extremely weak after 2 months, even though they don't necessarily have any other symptoms, and other people never experience that fatigue. So there's a wide variety of symptoms there. And again, it's hard to know, but I think with our bodies having MG and the propensity for us to experience weakness without having a virus, it would make sense that might contribute to it. So again, Bob, I'd talk to your doctor to see if you need to change your course of treatment, something, along those lines.
Good suggestion.
Okay.
I'm learning a lot in this last 10 minutes. So.
Well, good. Anyone else want to share anything? It's hard. I'm not seeing if you have a hand up or if I'm not seeing that. So maybe we could.
Craig? Yeah, Craig, I see you have a hand up there.
Hi, my name is Greg Knepp. I'm in San Jose, California. I was diagnosed almost exactly a year ago. My doctor is a neurologist in the Kaiser system. I suspect that she's treated probably a handful of MG patients before because it's a relatively rare disease. I'm sure this is common for a lot of you, but I feel like my doctor is not able to adequately answer a lot of my questions. So sessions like today are certainly very helpful where we have experts giving us input. But is there a way to get more one-on-one specific information either through second opinion type appointments, or have people had success in in getting educated beyond what their own doctor can do for them.
I have several people that have Kaiser in my group, and you are not alone in your feeling of having a neurologist not have a lot of expertise or not having had treated a lot of patients with MG within the Kaiser system. And my recommendation to them is to seek second opinions within Kaiser. Because I live up in the Sacramento, area, we kind of have we know who the Kaiser neurologists are there. And so, people have gone to different doctors. I have the names of 4, I don't have them with me because I'm not in my home right now, but I have the names of 4 doctors that are in the East Bay and San Francisco area that were recommended to me as Kaiser neurologists. So my information is on the MGFA website. If you want to email me directly, I'll be back home on Monday and I can get that information for you. And maybe you can request a referral.
And Kaiser.
I'm in the Roseville area, and I have a really good doctor there.
Through Kaiser, Bob?
Yes.
Okay.
I'd have to look back at my record.
I find out through Stanford that there were some neurology doctors, they went to Kaiser as well, but they live in the East Bay. I forgot their names right now, but Stanford, they do have a team of neurology that work with this type of what we have. So they will give us information about there were some 2 doctors from Kaiser that they moved from Stanford, they went to Kaiser.
Okay.
So
Those of you that have, I suggest that those of you that have a Kaiser doctor, that you put their name and where they're at in the chat. And that way they can, those that want to can access that, all right? That would be helpful. And then anybody that's not able to get what they need, contact me. All right, anyone else?
I'd have to look through my records, but I was diagnosed at Kaiser in San Jose. And then again, it's San Francisco Kaiser, but now I go to Stanford with Dr. Mapidi. I could look back up in my records and find out who they were. I can't remember off the top of my head. I've seen too many doctors in my time period, but can look them up for you and give them to you too.
Oh, awesome. Thank you.
My understanding is that UC Davis has doctors, I think including Dr. Richmond, who actually see patients in addition to just doing research.
Yes.
Well, Dr. Mapidi also, he's my doctor and I love him. And I just got to say, I mean, I've had a great relationship with him. He's given me a lot of respect and great care and has been very open to trying to help me be as active as possible. He's at Stanford.
Who's this?
Dr. Mapidi.
No, who are you
oh, I'm sorry.
Right
Deborah Vick.
Deborah? Oh, hi, Deborah.
Thanks for the input. I might have to look at changing insurance next time around.
Yeah, so he's great. I mean, I love him. I went from Kaiser to there, but also I have other underlying disorders. So they kind of were too confusing for everything. But Dr. Mapidi has been really great. And he's teamed with the other neuroscience specialists over at Stanford to help me with my other underlying conditions. So I've been really happy with him, just to put that out there.
Okay. Yeah. We'll take another, anybody else want to share or to introduce themselves before? I'm going to turn some time over to Dova. Do you want to do that, Dova, to thank our sponsors? Or
I do.
Okay.
I do. Thank you, Joy and Jessica, for putting on an amazing conference today. This is our first regional conference of 5 that we're going to have this year all over the country. So you guys kicked it off with a bang, and I appreciate all your hard work. I do want to thank the sponsors that have sponsored the regional conferences. They're Alexion, Argenx, Janssen Pharmaceutical Companies of Johnson & Johnson, UCB, and Immunovant. So they really make this possible for us, and we really appreciate their sponsorship. I encourage everyone to come to our support groups and to use the MGFA website to find anything that you need, and anything that you can't find, to please let the office know, let us know, and we will try to help you out and get you the information that you need. So I appreciate everyone for participating today. Again, thank you, Joy and Jessica, and all the wonderful doctors and therapists that spoke today. Thanks, everybody.
Thanks, Dova. We so appreciate MGFA's support of this. You know, when we stopped having in-person meetings, we were all very disappointed. And as much as I miss the contact, and I'm sure those of you that are support group leaders can echo that, I miss the in-person contact with my members. But it's been wonderful to be able to reach others that had not been able to come because of distance or physical limits or whatever to our meetings. And so this has been maybe a little tender mercy in the midst of a pandemic that we've been able to hold this. And we appreciate the sponsorship of these pharmaceutical companies and MGFA to help us to reach out in a time that's really been difficult for people. So I appreciate all of you being there. I appreciate the questions that were submitted. All three doctors said they were just blown away by the scope of questions that were asked to them. So they were impressed with you, really very impressed with you. So Jessica, do you want to say anything before we close off here?
There's one more question of when the next conference date is. Do we know that, Dova?
I do know that. The next conference will be the Southwest Conference. So it's going to be covering Southern California and Arizona. And it is Saturday, March 6th.
Cool. Great.
Well, thank you everyone for joining us. If you want more information on upcoming events, support groups, the conferences and all that, definitely check out the MGFA website. Besides support groups and meeting dates, there's a lot of great webinars and you know, information that you can do if you want specific information on specific medications, treatments, or what have you. They have all of that there available to view. So check that out if you haven't already. And thank you so much for making this first conference a success. We really appreciate all of your time today.
Everyone have a great weekend. Bye-bye.
Thank you.
Bye. Thank you.